Good morning, everybody, and welcome to the live operative webcast from the being done in the ages of the Urological Society of India and Indian School of Urology. This is being live webcasted from the Dr. Ram Manohar Lohia Hospital Department of Urology, and Dr. Hemant Goyal, who is the professor head of the department, would be the operating faculty. Dr. A.K. Mandal from Rishikesh AIMS would be moderating this session. It's a surgery which is not caught on. Actually, it's a good surgery, but not many people are practicing doing this perineal prostatectomy. Hemant Goyal has been doing this for quite some time, and I'm sure he'll be able to demonstrate his surgery. And this will be telecasted live from RML Hospital. With this introduction, I would now invite Dr. Arun Chawla, Chairman ISU, to give his opening remarks. Over to you, Dr. Arun.
Good morning, Dr. Keshav. Thank you very much, and warm welcome to all the viewers. And as Dr. Keshav told, today we are having a live demonstration of very interesting procedure, but very seldom performed by many urologists and many uro-oncologists, and that is a radical perineal prostatectomy. And as you are all aware, the procedure was almost a century back performed by Hugh Hampton Young, and later bit of modifications by Dr. Belt and further modification by Hoodman and all that, including nerve sparing training and nerve sparing technique. Almost the same results at the aortic radical. I think this procedure is quite important technique to provide, once say, oncological control with very low morbidity, a short hospital stay, excellent cosmesis. And probably the evidence also says that it has a similar quality of life outcome as compared to laparoscopic and robotic procedures. And I don't know, Miss, when we are with the procedure with Dr. Hemant Goyal, whether he has made a further modification in the technique, because he's doing this procedure for quite a number of years, whether he has made his own modification to provide a good oncological control with the equal safety and efficacy. So we have to see. But this a warm welcome again to all the viewers, and equally important is this session will be moderated by Dr. Arup Mandal, who has enough experience in a different type of prostatectomies, the open, the robotic one, for both the benign as well as the malignant condition of the prostate. A warm welcome to you, sir. With this, I hand over to Dr. Keshav and then Dr. Hemant Goyal for the further proceedings.
Thank you, Dr. Arun. I would now invite Dr. A.K. Mandal to take over and moderate, and then Hemant Goyal will have his presentation, and then we go on to the live webcast. Over to you, Dr. Mandal.
Okay, thank you very much to Urological Society of India, is our society, and the Indian School of Urology. I think we can straight go to the OT. Dr. Hemant, are you ready?
Yes, sir. It will take, I think, another 10 minutes to start the procedure. Till that time, if with your permission, we can have a short review on radical perineal prostatectomy, and later on, I can have a small video so that people are oriented what we will do, and then we can start the procedure, because many
Please
of
go ahead.
them. Okay, thank you, sir. So I think my screen share should be okay. Yeah. So first of all, I would like to thank the entire Urological Society of India, President Dr. Samne sir, Secretary sir, Dr. Keshav Murthy sir, Dr. Arun Chawla sir, and all entire USI Council for giving us this opportunity to demonstrate radical perineal prostatectomy. Also, I would like to thank our entire hospital staff, OT staff, our team of anesthetists, and our MS sir, who have again given us this privilege to operate on Sunday, because in a government hospital to operate on a Sunday is very difficult. That was the main hindrance last time also. So now we are here. Patient is almost ready. So I'll start with a small presentation. Radical perineal prostatectomy, and some modification we have done in form of lap perineal lymphdectomy. So we all know about the evolution of perineal prostatectomy and radical retropubic prostatectomy. Perineal prostatectomy actually came a bit much before than retropubic prostatectomy, but because of technical difficulty in teaching and demonstration, somehow retropubic prostatectomy took the lead, and then it modified to laparoscopic RRP then reduced sparing RRP. Now somehow we are coming back to the perineal route as a minimal invasive route, and truly reduced sparing approach through perineum. Same radical perineal prostatectomy in the form of robotic perineal prostatectomy is being tried in many centers, and I firmly believe the future is there of this technique when robotic is also application is applied to this procedure. So about the indication, so as such there is no contraindication of a perineal prostatectomy in all sort of patients. With only contraindication is when we cannot do a lithotomy position to the patient. Otherwise there is no contraindication if the patient can be in lithotomy position. Any prostate size, any patient characteristic, maybe a morbidly obese patient, we can do perineal prostatectomy in all. At least, and we had actually 2 patients today. One was not fit for GA, so we actually wanted to do that patient because that is the ideal indication of perineal prostatectomy. When the patient is not fit for GA, we cannot do a laparoscopic prostatectomy. Even a open radical prostatectomy is not, the patient is not very comfortable in a regional anesthesia, but perineal prostatectomy we can easily do in regional anesthesia. There is no need of any GA, so that is also added advantage. Plus this type of approach, this radical perineal prostatectomy give us a very nice approach to all type of surgery which we do behind perineal body. That is, if we do a rectourethral fistula and any so these type of the anatomy is very clear. So initially we were doing rectourethral fistula by York Mason technique. Now we do all our rectourethral fistula by this same route because the approach is same in rectourethral fistula. So in radical perineal prostatectomy, basically there are 2 approaches: young approach and belt approach. We follow belt approach. We just go above the anal sphincter. Only muscle we cut is a rectourethralis muscle, and truly we don't cut any muscle. We just retract all the muscles. The major limitation was a lymphnectomy. So it was, in my initial cases, it was limited to low risk and low to intermediate risk localized CA prostate, because in high risk prostate, lymphnectomy is essential. But somehow in radical perineal prostatectomy, it was difficult to do a lymph node through perineal route. Initially, we tried by a open technique, open perineal lymphnectomy. But Dr. Keller was a pioneer in this, who actually did a lot of cases, and he published his literature where he did a radical perineal prostatectomy with simultaneous extended pelvic lymph node dissection by the same incision. So after a prostatectomy part, he did a lymphnectomy through the perineal incision, and he was able to do a good like 22 lymph nodes were around removed from 11 to 12 lymph nodes from each side. We also tried open perineal lymphnectomy after completing perineal prostatectomy, but somehow it was technically difficult. We were able to see, but it was not reproducible. So we modified that, and now there are papers where they are showing robotic technique through perineum. So these some are some of the photographs where the initial dissection is like a perineal prostatectomy. Once we have visualized the prostate, then we dock the robot, and with the help of with that we can complete prostatectomy. The biggest advantage of robot will be to do a perineal lymphdectomy after we have done prostatectomy, because in prostatectomy I personally don't think there is much use of robotic instrumentation, but in perineal lymphdectomy, to do lymphdectomy from the perineal route, it will be very helpful. What we are doing right now is, we are, after completing prostatectomy, we apply silk sport to the incision site, and then by laparoscopic instrument we do perineal prostatectomy. But then again there is fighting of instrument. I think robot will be very helpful in that procedure. And the radical perineal prostatectomy, the contemporary resurgence of a genuinely minimal invasive procedure. The procedure provides a small incision, perfect access to the prostate, urethra, neurovascular bundle. It omits large muscles and vessels and yields excellent cosmesis. The operation time is short in reality, while vesicourethral anastomosis is very surgeon friendly. The procedure is successful even in cases that are hardly suitable for other prostatectomies, such as obese patient after large abdominal operation, transurethral procedures, and those with a larger prostate. RPP can be easily performed in a nerve-sparing manner as well. Newly developed operative techniques have made simultaneous transperineal lymphdectomy perfectly feasible. And only instrument what we require is a curved Lausley tractor is the only truly essential equipment. At the moment, there is no reason that a surgeon obtaining excellent functional and oncological result with RPP should change to a different approach. There is no doubt that as far as pain, complication, transfusion rate, continence, positive margin, and cosmesis goes, RPP meets every goal of minimal invasive surgery. And urologists may be abandoning an underutilized yet cost-effective surgical approach that compares favorably with its successors. So, like, just with this, I'll just start a small video till we are. So this is a small video where edited video where so I'll just discuss what difference we have made to the technique. So originally a very U-shaped incision was described along the anal margin. We have actually converted it to be a more of C-shaped incision because we think that with this incision the infective complications are less as it is a bit away from the anal margin. We create this issue-rectal fossa and we isolate the central tendon. Now, the initial part of the procedure, there are no natural sprains. We just go above the anal sphincter, and so this part we do very slowly because we don't want to injure anal rectum at the start of the procedure. So, in our like around 40 cases, luckily there has been no rectal injury. There has been zero rectal injury in any of the case. So once we are in this, we can see this is the prostate, and with the help of Lowsley, it makes the prostate a bit perpendicular, straight. So it's not flat. So here again, we expose the posterior surface of the prostate, and then we loop the urethra. So this we can see the urethra part, and we can preserve as much of the abdominal urethra as it's possible, because we can see the prostatic apex very nicely, and then we can cut. Then we make use of this straight Lowsley and do rest of the dissection. The posterior dissection is done. Anterior we can see. Then we can palpate the bladder neck and we cut the bladder neck. We again try to do as much as of bladder neck sparing. So we try to loop the urethra at the level of bladder neck also. This is not always possible, but possible in majority of the cases. So only this much of the bladder neck is open, which allows the Foley's catheter. So then one catheter will do traction. It will pull the prostate towards our side. The challenge is again it's a small incision. If it's a very large prostate, then it occupies the entire incision. So we have to give a lot of traction in those cases. Otherwise, in most of the cases, CA prostate size is around 30, 35, 40 gram, which can be easily done. So we cut posterior bladder neck fibers under vision and identify. Then after the posterior bladder fiber, the steps are same. We identify vas on both the sides, clip and cut it. Then we identify some anal vesicles. Again, we clip it and we cut it, and we retrieve the specimen. So after we do this, then in case we are doing a perineal lymphnectomy, we manually create the space, paravesical space on both the sides. We apply this silk port to prevent air leakage, and then we introduce our 5 mm or 10 mm laparoscopic lens. This space is already created manually by a finger dissection. Further create this space. This is the open bladder neck, small bladder neck opening. And we create both the windows just lateral. Here we can see the external iliac vein and external iliac artery from the perineal route. We preserve the obturator now, like we do in other approaches, and we remove this lymph node packet. Now this is the external iliac vein, and the lymph node dissection has been done. So this is the external iliac vein on the opposite side, and similar procedure is done on the left side. Now this is a bit technically demanding because the instrument fighting is there. There is limited space, and this is the best part of the procedure. The anastomosis. You have open bladder neck in front of you, urethra in front of you. There is no bleeding vessel, and the anastomosis part is effortless. It takes hardly 5 minutes to complete the anastomosis, and only in my third or fourth case, when I sutured the bladder neck inadvertently with the transverse perineal muscles, there was the urethrocutaneous, there was a anastomotic cutaneous fistula, and never there has been leak. But only thing is, during anastomosis, you have to take care the distal stitches should come from urethra, because the proximal bladder neck is visible. Urethra is coming perpendicularly from upwards. So I'll show how to take care of that. So this is the final incision. It's much away from the anal margin. Infective complications are also very minimal. So that's all about the procedure.
Okay, Dr. Hemant.
Yeah.
Dr.
Yes,
Hemant, thank you for this preliminary thing to orient the attendees. I would request you, after some of this procedure for prostatectomy is not well accepted, do not attract people because it's not very fancy, and our ignorance of the perineal anatomy, I must accept that. So as you do the dissection after the initial incision, as you deepen the incision, that part the incision today you show people so that, after that kind of blunt dissections, or as you said that there is no definite anatomical planes, how do we reach the apical part of the prostate?
Okay. So
I'll expect that today.
Yes, sir. Yes, sir. So, sir, that we will show that part. And just I want to say that we are doing radical perineal prostatectomy. We are doing actually prostatectomy by all routes. We are doing open retropeak prostatectomy also, perineal prostatectomy. We are doing lap extraperitoneal. We are doing lap transperitoneal also. So all four approaches we are doing in RML, and there are different indication for different patient. We are not saying that radical perineal prostatectomy should be done in all the patient, but definitely there are the subset of patient where this procedure is advantageous over other. And second thing, this procedure helps us to get orientation about the anatomy of that region, because as a urologist, very rarely we go behind perineal body. So this is one procedure where that anatomy is very useful. So with that, sir, the patient is getting induced. Spinal is being done. I think.
So I'll request two things. You give us a profile of the patient today you are operating.
Yes, sir.
And
yes,
second, if a beginner has to start after his initial orientations, what kind of prostate he choose for approaching from the perineum?
So please, अपना presentation लगाओ दूसरा laptop में. Sir, as a beginner, I'll say the patient profile, it should be a low risk CA prostate, low risk localized CA prostate, where we don't have to do a lymphnectomy. We don't have to take tension about doing lymphnectomy. So that is one thing. Second thing is the patient profile will not matter. In fact, initially I thought it should be a thin, lean patient in which perineal prostatectomy will be helpful. But later I have realized obese patient, it is more easy, because in obese patient there is more space in the perineum because of the fat. So somehow that is there. Third thing is about the prostate size. So a medium size prostate, a very small size prostate is difficult, and it is a very large size prostate is difficult, because very small size prostate, because during this procedure we have to repeatedly palpate the prostate per annuli, per rectum, and very small size prostate sometimes that palpation is not helpful. So to identify, so the most difficult part of the procedure is actually the initial part, where we have to identify the prostate. We go from the perineum and we reach the prostatic apex. Once that is done,
presence of the median lobe causes a problem?
Not really, sir, because in this, sir, we take care of this MRI pictures if there's a very large median lobe, but I have not encountered a very large median lobe in my procedures. But even if there is a median lobe, what we do is we cut the anterior bladder neck first, and we can actually see the median lobe in the posterior part. We can cut like we do in open retropubic prostatectomy. We can replicate that, and we never see ureteric orifice. They are much away from the. We have never injured. We have never seen also ureteric orifice. So that is not
Good.
there.
And you said that you would continue to palpate the prostate part rectally during the procedure.
Yes,
so
sir.
do you do any kind of bowel preparation for this?
So, no, sir. We just do enema is given in the morning of the surgery, and second thing is we apply condom catheter in the anal margin, so which helps us to repeatedly do a perennial examination without contaminating our fingers in the operating field. So, so that rectal packing is done during the procedure. We avoid peg leg or something like that because that will make stools very liquid and will contaminate the operative field. So a hard stools is semi-solid stools are better. So I think and I think about the prostate size I have already told sir ki it should be medium prostate size will help. It will be a easy like a obese patient, low risk patient with a medium size prostate. Medium size is like 30-40 gram prostate. I think that will be ideal patient for starting. And only my advice is we have to go slowly with this procedure because there are no major vessels, but everything is oozing. There are some minor capillary vessels are there. So and there is a sharp dissection also. There is blunt dissection also. So if we are not doing it patiently, it will start oozing from everywhere, and that will make it more like a blind procedure. So I avoid that. I generally don't do that. In none of my cases there has been rectal injury. None of the cases I have to convert it to open, and so I'm pretty sure we'll be able to demonstrate a good perineal prostatectomy. Let's see. So just give me if there is time I can show the instruments and
show it.
Okay. ये ओपन है कितना टाइम लग रहा है इसमें से तो एक मिनट यहाँ पर यू कैन फोकस है मुझे सर का आवाज आएगा ओके हेलो am I audible sir?
Yes.
Yeah, so sir these are the basic instruments. Actually they are taking around 5 to 10 minutes more to induce the patient. It's being done in regional anesthesia, and just I'll show you some instruments. So these are two very important instruments. This is a curved Lowsley. This visible?
Yes.
So this is a curved Lowsley. So at the start of procedure, we first put catheter to see there is no urethral stricture. So once that is ruled out, we just put a dilator. It goes inside the urethra. We'll open it by clockwise rotation. So this will be a self-retaining mechanism, and then we can manipulate the urethra. And this will not obstruct the urine because there is a channel from where urine will drain. So it will not distend the bladder. Because if the bladder is distended, again there will be a problem. So there is a channel which will drain the bladder, and so the bladder will not be distended. And by this we can manipulate the prostate. So normally,
so this will help you to displace the prostate downwards during dissection.
Sir, two things it will do. When I perpendicularly raise it, once the prostate normally is flat, it is flat. So if in a flat prostate, I'll first go to the apex of the prostate. But once the prostate is straight, two things it will do. It will bring the prostate caudal towards me, and second thing, it will make it perpendicular. rather than flat.
Good.
So
Yeah.
first I'll approach the posterior surface of the prostate, not the apex of the prostate.
So
it
this
will
is
help.
one of the essential instrument needed for this procedure.
Sir, this is actually essential, more essential for demonstration of the procedure, because otherwise, sir, actually we got it a new 2 days back only. So from last 4 to 5 months, we were doing it without Lausley tractor, but we were able to do because we have done a good number of cases. Otherwise, it would have been difficult. Like we can do the procedure, but this will help us in demonstration.
This is available with any manufacturers?
Sir, this is not available anywhere in India. By a lot of effort, we got it imported from US, and there's a company Symmetry, which was making it in US, and from there we got it, and it just got delivered to us 2 days back. Oh, because so this is the curved one.
You can aim for indigenous modifications.
Sir, there are some indigenous modification, but what they are doing, they are actually making it is of a smaller length. One company in Ludhiana, they have made it, but of a smaller length. And second thing is, it is not of 16 French. That is around 10 French. So it will not help that much. We want a study. Second thing is, this is straight Lausley. This is straight Lausley. In the second part of the surgery, this is being used. So. Yes, sir, I think if there are any question we can take, because it will take 5 to 10 minutes. The patient they are taking some time in inducing the patient.
Okay, once the anesthesia is done, you will explain us the position of the patient, because that is one thing very important. And meanwhile, you can give us the profile of the patient.
Okay.
Being operated today.
That's okay. ये लगना होगा, इसको कनेक्ट करना है वहाँ पर। Okay, sir. So this is a 65-year-old gentleman. He complained of lower urinary tract symptoms, voiding more than storage for last 3 months. There was no history of hematuria, pyuria, dysuria, or acute urinary retention. He is a known case of hypertension and hypothyroidism on medication. History of previous left URSL in 2016. On examination, per abdomen is soft, non-tender, no palpable organomegaly. On digital rectal examination, it was a grade 1 prostate. A hard nodule, 0.5 into 0.5 centimeter, was felt in right lobe. Lateral sulcus are free. Overlying rectal mucosa is free. Trust biopsy, PSA was PSA was 15.7 nanogram per ml. Trust biopsy was done. Trust biopsy shows a prostatic adenocarcinoma. 5/12 cores were positive. Maximum core involvement was 80%. Modified Gleason score was 3+4, 7, and Gleason grade group 2. And perineural invasion in right mid-lateral core was present. So rest of the routine investigation were normal. Ultrasound is also normal. In MRI, abdomen, pelvis, we have done actually after biopsy. So there is a lesion in right peripheral zone at mid part of the gland. Lesion abuts prostatic margin. Bilateral seminal vesicle and rectum were free. No lymphadenopathy. Rest was within normal limit. So this is the T2 weighted image. Metastatic workup, we have done bone scan. There is no evidence of any metastatic lesion, and chest X-ray was normal. So it's a low to intermediate risk localized CA prostate.
Okay. Gleason score 3+4.
Yes,
and
sir.
PSA is 15.
Yes, 15. Sir.
PSA is 15.
So it's a intermediate risk CA prostate, sir. Sir, a plan is radical perineal prostatectomy. After the procedure, our aim is to first demonstrate a good radical perineal prostatectomy. During the procedure, if all goes well, then we can show you a bit of lap perineal lymphdectomy also. Otherwise, main aim is to show a good perineal prostatectomy today.
Okay.
Hemant, how long do you wait after biopsy for surgery?
Sir, normally we wait for 6 weeks, but in this case, it's been 1 month.
Okay.
Otherwise, we wait for 4 to 6 weeks, like minimum 4 weeks, but maximum 6 weeks. So, sir, we have operated after TURP also. We have operated post Hollep patient also, perineal route with closed bladder neck also, where there was no access to catheter. That patient also we have operated transperineal prostatectomy, bladder neck reconstruction also we have done from the perineal route. So it's versatile. Like in most of the cases, we were successful in completing the procedure. So the most challenging was the one where there was a complete bladder neck closure post Hollep. So in that we were not able to negotiate even a catheter. So there was no excess of Lowsley, no excess of catheter. So, but we were able to complete that procedure perineally. So
Yeah,
I'm
this
very
kind of
sorry,
case
but
you have attempted because you had the experience of doing some 20, 30 cases before that.
yes, sir. Yes, sir. Yes, sir. That is why, and in that actually, when we thought we had no other option, because if we were how like with a bladder neck closed bladder neck, and even an open radical prostatectomy was a bit difficult because there was no excess of catheter. So in retropubic approach also, I thought it will be difficult to do retropubic prostatectomy. How to identify urethra. So so that was a main difficulty. So we thought we'll go with perineal prostatectomy, and it went well.
On average, what is your operating time for the perineal prostatectomy, radical prostatectomy?
So on an average, it takes 2.5 to 3 hours.
3 hours. Okay.
Yes,
Fair
yes,
enough.
sir. So sometimes I complete in 2 hours also, but on an average, it is 2.5 hours. Sir.
Okay.
And
Do you need transfusions?
Not really, sir. Not there is no much blood loss. I think 200 ml, 300 ml blood loss is there, and no major bleed is there. There's a bit of oozing is there, but there's no major blood vessels, so we don't need transfusion.
Okay, good. So it appears a safe procedure from many sides. From many sides.
Yes, sir.
And the patients are back to a normal diet and up and about by the next morning.
Yeah, sir. The recovery is very good. There is a rectal pack which is removed next day. Like in VVF all the surgeries, we remove the rectal pack next day, and patient is mobile from day one, sir. He full oral diet, and by maximum by day 3 he is discharged.
There's
So
a question
one
from
question.
Dr. Shekhar. There's a
Yes.
question from Dr. Shekhar. Is asking, is SPC needed in selected cases?
No, sir. No, sir. I have never put a SPC in any of the case. And normally we don't put SPC in any of the case of like in VVF also in any only in PFUD we put SPC. Otherwise, radical perineal prostatectomy we are never required to put SPC. In one case, in my third case, there was a leak from the anastomosis. In that case, we have put SPC, but that was not able to help because it is a dependent anastomosis. Actually, leakage from the posterior part of the anastomosis. Unlike in retropubic approach, actually the posterior part is there is nothing. Here the posterior wound is open. So if there is a urine leakage, it will not stop from SPC. So in that case, we have to re-explore the patient, and we re-anastomosis, and then the patient was very fine.
There's a question from Dr. Venugopalan. How will we control if there's any bleeding which occurs during lymphadenectomy?
So, sir, actually, that will be very difficult to control. There are two areas where I always fear. One is DVC, and one is external iliac vein or artery. So, I also thought, luckily, never there have been no like in my case there was no injury of external iliac vein or artery. Just a minute, एक मिनट यार, उनको बोलो. So in my case, there was no injury, but I had a talk with Dr. Keller. He said in his case, there was an injury to external iliac vein, and he repaired it through the perineal approach. But I am very careful. I don't want to injure because I feel it will be very difficult to control from the perineal route. And DVC also, luckily there was no injury to DVC. I have seen one case where there was an injury from one of our faculty from the bleeding from the DVC, and that was repaired. So a suture was taken, and they were able to control it from the perineal route.
Is there any contraindication? This is a question from Dr. Sanjeevan.
Sir, the if the patient we cannot put in lithotomy position, that is the contraindication. And obviously, sir, very locally advanced cases or high risk cases where there is, like, I'll do a cystoscopy. If it's very close to ureteric orifice, then should be avoided. If you think ureters can be damaged, so in that case, I think doing a ureteric reimplantation from the perineal route will be difficult. So at present, if then we cannot put the patient in lithotomy position, then I won't do a perineal prostatectomy.
Dr. Sanjeevan is asking another question. Would you recommend it in a renal transplant recipient?
So I think if there's an indication of radical prostatectomy renal transplant recipient, there is no contraindication to me. In fact, I think it will be better because abdominal in a retropubic approach, there is already a extra kidney and there will be some altered anatomy. So I don't. So in a perineal approach, we will not disturb the transplanted kidney, but abdominal approach we may like manipulate it. So I'll prefer a perineal prostatectomy in that scenario.
Dr. Hemant, if your patient is not yet ready, I'll ask.
Sir, he is ready. Sir, he is ready.
Okay.
Okay.
Then you go ahead.
So
Go ahead.
induction is complete. So induction is complete, sir. I'll just tell you about the position and then I'll wash and I'll start the procedure. I think
sure.
that okay.
Go ahead.
So, एक स्क्रीन लगा दीजिए प्लीज स्क्रीन ठीक है रेडी है ठीक डन है ठीक है ये हटा दो पहले हटा दो मैं कर दूंगा आराम से लगा तो ठीक है तो आई थिंक बोल्स्टर शोल्डर सपोर्ट भी लगाना होगा एक बोल्स्टर लगा एक मिनट So this is the patient is under regional anesthesia, and we can use simple lithotomy stirrups also, and we can use Allen stirrup also. I personally prefer Allen stirrup because then we can manipulate during the course of procedure the position of the patient. And इसको ठीक करो यहाँ से लूज करो ऐसे करो फिक्स करो ठीक है ठीक यहाँ पर भी यहाँ पे फिक्स करो ये लो बोलो चलो फिक्स करो ठीक है ठीक है यहाँ पर नीचे the buttocks of the patient should be at the edge of the table एक बोल से हाँ बस ठीक है और इधर लाओ एज ऑफ द टेबल लाओ ठीक है ठीक है थोड़ा सा और इसको लूज करो इसको ऊपर ले गया ऊपर ऊपर करो ऊपर 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 बस अब ठीक है अब फिक्स करो ठीक है यहाँ पर भी ऊपर करो ऊपर और ऊपर अब फिक्स करो आराम से फिक्स यहाँ स्क्रीन लगा दो बीच में स्क्रीन लगा दो जो हमारी स्क्रीन लगा दो हो गया ठीक है so sir this is the position of the patient we start with this position it's a very simple position it's a simple a bit of extended lithotomy we can with the help of Allen stirrup we can extend during the course of the procedure whatever we want to do and the head low also we start the procedure with 10 to 20 Tredelyan bugs only when we are dealing with the bladder neck and apex of the prostate that time we'll do it a bit more of head low so there should be shoulder rest so that during that head low the patient will not go back so the buttock should be at the edge of the table all the time of the surgery so if there is no shoulder blades are not there so during head low the position will push towards the anesthetic and then there will be a difficulty in doing this
do you use
yes
do you
yes,
use any kind of sandbag or a bolster under the buttock
so simple one bolster is there nothing very fancy thing only one bolster or something can be used, we can do without that also, because very large bolster if we will apply, it generally slips during the surgery, and the
patient will be unstable.
yeah, so I don't use a big bolster, a small bolster, just I use, sir.
So your aim is to that the perineum should look towards the surgeon. Is that
Yes,
correct?
sir. Yes, sir. So the perineum should look towards the surgeon. So we'll do a bit of head low, so that will make it easier. So sir, I'll start, sir, painting, dripping, and then after dripping, I'll also wash. So
Go
till
ahead.
dripping. Go ahead.
No. At this stage, I would definitely like to emphasize the position of the patient during any operation. See how carefully Dr. Hemant padded the patient from the pressure points. He himself so supervised the position so that during the procedure there is no difficulty. This is true for anything, whether you are doing ureteroscopy, whether you are doing any urethral reconstructions or this procedure. So importance of the patient on the table is extremely important.
If there are any questions, the attendees can put it on the chat box. Dr. Mondal or I will communicate with the operating faculty.
Potassium 5.3 to correction antihypertension. Admitted post-op error.
Hello. Hemant, can you hear me?
Yes, sir. I'm just.
There's a question from Utsav Shah. He's asking, what if the patient has stricture? Can we do something during the prostatectomy itself?
Sir, I'll just answer in 2 minutes, sir. 2 minutes. 2 minutes, just.
Okay, okay. Take your time.
Just 2 minutes. मुझे वो यहाँ बताओ, चेयर दो, चेयर. Mob do it. So, hello. Hello.
Yes, Hemant. Dr.
Yeah,
Hemant,
sir.
go ahead.
So, sir, we have not encountered this situation, but generally we do rectorectal fistula with stricture or PFUDD. So in that case, sir, we will have to do dissection at two levels. We will have to do a dissection posterior to perineal body for radical perineal prostatectomy, and second dissection we will have to do, like what incision we go, that we have to extend longitudinally upwards, and second dissection we will have to do anterior to perineal body to manage urethral stricture. Both can be done together, but the approach will be different. Incision will be same, approach will be different. One will be posterior to perineal body, second will be anterior to perineal body. I'll just show when I give my incision how that modification is done. So you can see the this position. ये यहाँ से नहीं आएगा, ये मेरे राइट शोल्डर से आएगा. कैमरा जो आएगा मेरे राइट शोल्डर से आएगा, उधर से फोकस नहीं हो पाएगा. इसका हाइट कम होगा, कैमरा विल कम फ्रॉम माय राइट शोल्डर. हाँ, राइट शोल्डर से आएगा और बिल्कुल शोल्डर के लेवल पे आएगा, ऊपर से आप अंदर का नहीं दिखा. ठीक है, ये 6 है. मैं स्टार्ट करूँ. तो फर्स्ट थिंग इज we'll do a anal. These are two condom catheter and there is a small gauze piece inside it. अब रुक जाओ. तो मुझे ग्लव्स चेंज करना होगा, कोई बात नहीं. Our DRE is being done. I can see. I'll introduce this.
The focusing has to be.
You can adjust the camera so that the operator, whatever operator is doing, can be shown.
मुझे ग्लव्स. एक मिनट, आपका कैमरा का हाइट कम होगा, डोंट. मेरा फेस जरूर इम्पोर्टेंट नहीं है. अब सिर्फ ये जो यहाँ पेशेंट का जो पेरिनियम वाला पार्ट है ना, यू हैव टू फोकस ऑन दैट. ये लो, ये फोकस मैं करता हूँ भाई. फोकस अभी आराम से. आप पहले हाइट कम करो, इसका हाइट मेरे शोल्डर से आएगा. अगर ऐसे आएगा ना तो आप नहीं दिखा पाओगे. हाइट शोल्डर. टेबल की हाइट बढ़ा दो, टेबल की हाइट बढ़ा दो, हाईएस्ट कर दो, बिल्कुल हाईएस्ट कर दो, और हाईएस्ट कर दो. हाँ ठीक है, नहीं कोई बात नहीं, मेरे से टच हो जाए कोई बात. ठीक है, वहाँ पर लाउसले का वो लगा देना, स्ट्रेट हैंडल. बस ठीक है. थोड़ा सा मेरी चेयर की हाइट थोड़ा सा कम करना पड़ेगा, मेरी हाइट से बचे. ठीक है आई थिंक ओके. एक वो दे दो मुझे, ड्रेप. हाँ ड्रेप दे दो.
Please adjust the camera so that we see the operative site.
Sir,
Yes.
Sir, can you see now?
Yeah, it is better.
Yeah. So I'll do just some minor preparation, then only I'll start.
Why did you put a urethral Foley catheter at this stage? Because you'll be using the Lowsley retractor.
Sir, I'll convert it to Lowsley. Actually, okay. I will only put Lowsley. These reconstructive I actually don't allow others to put, because if there is injury at the start of the procedure, it will be difficult. So cut. ठीक है, ये लो एक और ये दे देते. So sir, what we have done is we have just draped the forceps. We have put a condom catheter in the anal margin. We'll stitch it to anal margin because repeatedly we will have to do DRE. So to keep the fluid sterile, we'll just stitch these to the anterior margin. So that this condom catheter is fixed. Cut. Jelly ready है?
Yes, sir.
So these are some basic preparation which is actually already done in most of the cases when we start, but I just wanted to show them. So we are taking some time in this.
That's good. Do you use a headlight for operating?
Sir, I don't use, initially again we were using the headlight basically to record the cases, but my head is not stable. So that recording is always blurred. So we record. So generally, sir, I think your light is fine. So मुझे बताओ जल्दी. So before fixing the scrotum, I'll use this. Police आराम से चला गया था. एक सेकंड. ठीक है. So we have just introduced the Lowsley tractor. So by clockwise motion we'll open it. Okay. So it's almost fixed here. So we have done it before fixing scrotum, because once the scrotum is fixed, then this is very difficult to introduce.
Okay. Yeah.
ठीक है. तो give me scrotal suture, fixation suture. बस इसको ज़्यादा पुल नहीं करते, इसकी जरूरत बड़ी है. लो. Leave it. छोड़.
There's a question from Dr. Shekhar. He's asking, if the ureteric orifices are very close to the bladder neck, do you do pre-procedure stenting?
Sir, no, sir. Sir, never required a pre-procedure stenting. We don't even do a cystoscopy, sir, to see the position of ureteric orifice. So if we have any doubt, we'll do the scopy from inside after we have opened the bladder neck, if we have any doubt. But for initial cases, I have done scopy, so it's always very far away. So I'll start the procedure. So this is our basic preparation. We have put a condom catheter in the anal opening. We have fixed the scrotum, ideally, so it's okay. We have this thing Lowsley in position, and that's it. So I'll just mark the incision. I'll start. Hopefully it's visible. The incision site, everything is visible.
Yeah, Dr. Hemant, just tell the landmarks of your incision for the learning of the students.
Yes, sir. I'll draw and I'll show you. ये इंस्ट्रूमेंट वाली पकड़िए, मुझे वो मार्कर दीजिए. So sir, these are two ischial tuberosity which I can feel. So this is one ischial tuberosity. This thing here, there is second ischial tuberosity. So these are my lateral limit where I can use the incision, because these are bony landmarks. So I cannot retract bones laterally. So this is the maximum. This is actually the maximum space I'll get. This is the posterior ischial tuberosity. So this will be the maximum space I'll get. मुझे mark कर दो. So normally the incision which people used to take is something like this. The original this thing. What we take is we take incision. We have just modified incision like this. So the original incision which is described is more around the anal margin. What we take is we take incision like this.
At this stage, let me ask one question. Since
Yes,
you are disconnecting the muscles from the central tendon of the perineum, does the patient in the follow-up period complains of anything related to his defecation or anal sphincter control?
Sir, no, sir. Patient has not complained post-op of any such symptom where he has difficulty in passing motion or any incontinence about flatulence or anything. It has been reported in literature, but our patient have not actually complained about this any of such symptoms.
Okay, please go ahead.
Okay, sir. I'll start the procedure. वो लाउसले का वो लीवर ओमनी का लगा दिया उधर, ओमनी का ब्लेड लगा उधर, दो मुझे दो ये दो एलिस, मुझे इंस्ट्रूमेंट ट्रे दे दो। अच्छा दूसरा सेकंड कॉटरी But if there is any problem in vision, then just let us know because we can change the position of camera then.
So far
Normally,
it is okay.
So we create this two lateral ictiorectal fossa and we isolate the central tendon like this.
Yeah.
ले लो दो सिंगल हुक रिट्रैक्टर, सिंगल हुक रिट्रैक्टर लो, नहीं सिंगल हुक लंबे वाले पतले वाले लैंगन बैठ आराम से स्टेबल, कोई बात नहीं, एक और दो मेरा एलिस क्या ठीक है, ये मैंने आराम से कैमरा ठीक है, राइट एंगल कॉटरी लो आपने, हार्मोनिक भी रेडी है ना, ठीक है, अभी जरूरत नहीं है मगर ठीक है।
You are deepening the ischiorectal fossa. At this stage, you are away from the anal sphincter.
Yes, sir. So we create. So these were like I have done DRS. This is the anal margin. In one finger is an anal canal. So this will help me to for in my initial dissection. Or okay, just it. Okay. So the initial part is a bit. Again, just I said I'll go a bit slow in the initial part. Around. So you can see the muscles. There are some muscle fibers. You have to be below that. Because if we go above that, that will encounter the urethra above the perineal body. So we have to be below all the muscles.
Yeah. What are these muscles? Just for the students' benefit.
Sir, these are transverse perineal muscles. You can see the transverse orientation of these muscles. Like.
Okay.
These are the transverse perineal muscles. So we keep on retracting these muscle upwards like this. Like this. Okay. Light थोड़ा focus करो इधर. थोड़ा head low कर दो position. ठीक. एक. Okay. ठीक है. Good. काटना और नीचे से नीचे. वरना ये दिस विल बी ऊपर ऊपर ये तो मेरे मसल कितने बड़े एक बस ठीक है. परेशान कर रहा है. क्लियर हो रहा है. फोर्सेप ऐसे ही. टूथ नहीं प्लेन फोर्सेप दो. ठीक नहीं आ रहा. बस यहाँ से ले रहा है ना. फोर्सेप लेना. ये देख रहा है. ये देख रहा है. नो फोर्सेप दो इसको करण को पढ़ने ये छोटा सा. ये दिख रहा है. हाँ ठीक है.
During this stage of the dissection, the rectal finger is extremely important.
Yes, sir. So that is why we are a bit cautious during this phase. because once prostate is exposed, then there will be no chances of any rectal injury. Here, my one finger is constantly actually inside the rectum. It's like it's feeling.
So you are protecting the full thickness of the anal canal and its sphincter and the rectum.
Yes, sir. उठाना पड़ेगा, अंदर नहीं, इसको ना परपेंडिकुलर ही आपको रखना पड़ेगा, ऐसे परपेंडिकुलर, ठीक है.
The retractors they are using are right angle retractors.
Langenbeck, sir.
Langenbeck, okay, of different lengths.
ठीक है, अब ठीक. थोड़ा सा और हेड लो करोगे, हेड लो.
The cameraman has to center it properly.
Just yes. चलो ठीक है, ठीक है. I think this prostate has come. नहीं, मैं अभी लगा रहा हूँ बस, ये ना एक बार फिर रिट्रैक्टर बार बार चेंज करना पड़ेगा. सर इस prostate has come. सुप्रीत, ये ना ये दिस रिट्रैक्टर हैज टू बी परपेंडिकुलर अपवर्ड्स, है ना. इसमें अभी अभी यहाँ पर थोड़ा मैं आई अप्लाई दैट रिट्रैक्टर. So what I'll do, sir, I'll apply the Omni track for a better vision. Just give me again. छोड़ दो. Omni track का मुझे हैंडल देना. So I am till the almost on the posterior surface of the prostate. I'll apply the Omni track. वहाँ लगा हैंडल. रिंग दो Omni track का. बोला था. हाँ. ठीक है. ओमनी ट्रैक यार हैंडल दो ना यार, क्या कर रहे हो यार. हम हैंडल बोला तो है लगाने के लिए, लगाओ तो. इसको ऊपर करो रविंदर, और पास में, मेरे पास में जितना पास कर सकते. दो रिंग दो, पेरिनियल रिंग. दो पेरिनियल रिंग दो. हाँ यार, पेरिनियल रिंग एक ही है, ओल्ड और न्यू में नहीं है, एक ही रिंग है पेरिनियल. छोटी वाली पेरिनियल रिंग दो. इससे छोटी वाली है ना. हाँ ये वाली.
You can try to improve the light at the depth.
No.
लाइट फोकस कर दिया, ठीक है। अब वो मुझे ऊपर का लैंगन सिंगल हुक डिटेक्टर लैंगन बैक, हाँ चलो ठीक है बस। तब सिंगल हुक से डिटेक्टर से यू विल जस्ट शो दिस, ठीक है, और कुछ नहीं करना। वेरी गुड, चलो ठीक है सर। नाउ आई थिंक द विजन इज बेटर।
Yeah, it is better.
Yeah. So sir, we usually apply these retractor after we have done some initial dissection. So that is why I was not.
So the two blades of Omnitrack is retracting laterally, and one right angle retractor is taking things anteriorly, exposing the field. There was just a question that Omnitrack retractor is an imported retractor set of retractors, and what is the cost of the whole set?
Sir, this the entire retractor that is around 10 lakh. It includes for all perineal surgery, abdominal surgery, everything.
Yes,
so I think sir,
along with this pen.
Yeah. Okay. आराम से देखिए, इसको करंट को दो तो तुम्हें अगर दिखने लगे। करंट कम करो। So here we are very careful because we can see the rectum here, this part.
Yes.
And here it's the prostate. With this movement, just hold it like this.
So your rectal finger can put it back.
Sir, this finger is the anal canal. So
okay.
this is
so
the
you are
rectum
feeling
part.
the apex of the prostate?
No sir, it's the posterior part of the prostate.
Yeah, posterior surface near the apex.
Near the apex, more towards the apex. So we'll
Yes.
preferably more towards the apex to our entire focus is actually on preventing the rectum injury during the initial part of the procedure.
Very true.
एक बार ये निकालो, इसको थोड़ा ढीला करो आराम से। Sir, I am feeling the prostate, so I am just creating this lateral window, lateral to the prostate, because rectum will be adherent to the posterior part, but not to the lateral part. So this is easily created manual with the digital dissection. So it will help me in proper placement of these lateral retractors. And so I will just introduce it inside. Now I'll retract it. So this prostate is now free from the lateral wall. this side. Same thing I'll do on this side. Okay.
So you are staying close to the surface of the prostate and
Well, I'm
doing
just on the surface of the prostate. Just a minute. Loose karo. Up to tight. So I think you can see both my finger have gone lateral to the prostate. This is the prostate and this is the rectum. Is it visible?
Yes. Yes.
So this is the posterior surface of the prostate. This is one lateral surface. This is second lateral surface. I'll just.
Now you define the anatomy of the apex of the prostate.
Yes, sir. First, I'll do. Sir, I always try to do posterior dissection first, as much as I can, so that the entire rectum is away from the prostate till the level of bladder. If I'm able to do that.
So will the prostate dissection? Will the prostate dissection will be more difficult because of the denominator fascia?
Yes, sir. So I'll just incise a bit of denominator fascia. Whenever I have a doubt, I'll just.
As you do this, I see that you are using a right angle dissector, and to avoid a injury to the rectum, you will be closer to the prostate.
Sir, not in the surface, only the denominator fascia part. And we expect some addition, sir, because the biopsy was done just 3 to 4 weeks back. So here there will be some oozing, but I'm not going into the prostate.
Yeah.
वो है malleable retractor. So I think this is we have separated the rectum.
You have found the plane.
Yes, sir. No, now I don't need my finger in the anal canal. So,
okay.
So this is a malleable retractor, which I can. So just this is the posterior surface of the prostate. So I think it's visible.
Yeah. Yeah,
so
it is visible.
These will be the pedicles, and this is the posterior. This is the lateral surface. This is the posterior surface. So I can just do with the help of malleable retractor. I can.
Yeah, urethra will be coming more anteriorly.
Yes, sir. Sir, urethra will be somewhere here.
Yeah. I asked this question specifically to orient the students. It will be better so that whole anatomy, we are not used to see this anatomy normally.
Yes, sir. So I'll just, once this thing is done, better able to see. So the first hindrance is over, because now the entire rectum is down. So if I want to do seminal vesicles also, I can actually do it. I can incise the seminal vesicle will be here. The seminal vesicle will be somewhere here. So I can actually do seminal vesicles and vas from this also. If you want, I can do. Otherwise, it will be easy to do from front.
Okay. After you have disconnected the urethra from the prostatic apex.
Yes. यहाँ से कर लो, यहाँ से. So sir, actually, now you can see we have not incised this thing prosthetic capsule anywhere. The entire rectum is down. This is the posterolateral pedicle. Right angle though.
This is a device retractor you are using posteriorly.
This is a malleable retractor. Malleable.
Okay.
So actually in again this perennial surgeries, this एक मिनट जाओ, क्या करना है? डीवर रिट्रैक्टर क्या करना है? अच्छा एक मिनट जाओ, कर दो, एक सेकंड, हाँ करो, ठीक है, ओके। तो फिर आपको अपना ये हाई अप रखना पड़ेगा, ठीक है। So sir, we can fold, we can actually this is very helpful in this sort of surgery because the normal devers they come with fixed flexion, and again most of the procedure you have to do by your own because there is no enough space for assistant to help. So these are the posterolateral pedicle which we can see. We can clip it and cut, or we can use of harmonic. Harmonic.
The light is can be made better.
Light focus. Light. Sir, can you see these posterolateral pedicles now?
Yeah, we are able to see it. If you see better, then the students will understand better.
Please focus,
Yes.
Dr. Mish. Dekh lo.
Focus. We are only focusing the left camera, which is showing this pedicle only.
Acha. So we are focusing actually the left camera, which is showing this pedicle. So
Yeah, right pedicle you are seeing it.
yes. So harmonic section karte do. So as you can see, sir, there is no much bleeding as such. So this is the one pedicle. Okay. So we have disconnected one pedicle. नहीं अभी रुक जाओ, एक मिनट। Similar, some we can take care of the opposite pedicle. Yes. So with this loosely also will help us because we can just mobilize the prostate upwards. So it will create the better space. Like with this, there is a limited space. When I do this, there is more space. Can I appreciate?
Yes, yes, yes.
Just do it like this. So this will help me in doing my lateral dissection again. Harmony.
This meeting is being recorded.
गॉस पीस दीजिए, ठीक है। So I think my posterior dissection is almost complete. I actually wanted to show you the seminal vesicle from this side. So basically, if I want to dissect seminal vesicle, then I will have to connect, incise denonvenal fascia at this level also. Then only I will be able to approach vas. But it will be difficult to demonstrate, so I'll do it from the anterior side. Ab gauze please. We'll do some packing downwards so that there is no bleeding. Again, now it's very important for the anterior person to retract this thing. Okay. At this point of time, we can actually remove our this thing loosely, and we can introduce simple Foley's catheter. I'll just change it in some time. So now this is the posterior surface of the prostate, lateral surface, both lateral surface. We have incised a bit of posterolateral pedicle. Now we are approaching towards the apex of the prostate. Okay. नीचे बिल्कुल प्रोस्टेट की तरफ। पीनट बेटा एक ना आप एक ही रिट्रैक्टर पकड़ पाओगे और मुझे एक मिनट छोड़ो हाँ, ये ऐसे रखना है, ठीक है। ठीक है, वेरी नाइस। अब आप 2 रिट्रैक्टर ले लो, इसको चेंज करना पड़ेगा, फोली से चेंज करना पड़ेगा। 1 मिनट का। So we'll change Lausle. The work of the Lausle has been done. Now we'll change it to Foley's, because when we want to approach the apex, there should be soft catheter inside. Otherwise, we'll injure urethra.
Yeah.
So with the so we have removed this thing.
This is to avoid injury to the urethra.
Yes, sir. Yes, sir.
If you have a metal
Catheter.
catheter, you might injure it, or there may be
Yes, sir.
diaphragm injury.
If with a metal catheter we'll try to dissect, it will not loop. We won't be able to loop it.
Yeah.
So that is why when we want to loop, when we want to loop the prosthetic urethra, the urethra just distal to the prosthetic apex. So we'll first change it to a soft catheter.
Yeah. Dr. Hemant, you are being watched by so many people, but Professor Venugopal, at this senior age, he is as young as any one of us. Even I am older. I am now running 67. So Professor Venugopal has always shown his enthusiasm. Thank you, sir, for watching.
Sir, and I think we are very lucky in urology fraternity that I think this is a field where always all our seniors, they motivate us to do at this young age also. They motivate us to do good work, and they always appreciate. And so I think the urology fraternity, all seniors and colleagues, they are always very supportive. दो मुझे दो लैंगन मैक दे दो.
That's how we make progress.
Yes, sir. Yes, sir. इसको उठाओ. Apex, I am using extra retractors. I just want to show a good apex. That is why. So okay.
Professor Venugopal, sir, you can make a comment.
Malleable.
I'm seeing this perennial procedure or a perennial approach after about 40 years in my life. I think in the earlier days, we used to do perennial prostatectomy for benign prostate, not for malignant prostate. Though originally it came from malignant prostate. But over the time, I think we have done more perennial prostatectomy for benign conditions.
Focus करना
And
पड़ेगा.
one thing that I must tell you all, although you don't remember when I've not done the history. The first perennial prostatectomy was done by Susula in about 500 BC. And that's the time when we do not know whether we had done it for malignancy or for benign. But definitely, literature states that we have done perennial prostatectomy and with varying results. I hope I have made my comments already.
Thank you, sir.
उसको पुल करना कैथेटर को. हाँ, दोनों छोड़ दो. इसको कैथेटर पुल करो एक बार. मुझे नहीं आता. The retractors will be rearranged. Some finger dissection again I am doing. Anterolateral posterior of the prostate. Just in a minute I'll rearrange. ये लूज करो. तो मत छोड़ो. आराम से. तो ऊपर ले लो. हाँ, ऐसे रुक जाओ. चलो इसको पूरा ओपन करो ना, तब जाएगा. नहीं हुआ नहीं. हाँ, चलो टाइट करो. ठीक है, ये भी खोलो. एक ऊपर 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 नहीं थोड़ा सा नीचे थोड़ा हाँ बस ऐसे करो ठीक है ये भी फिर से रीअरेंज होगा बस वो करो उसको जस्ट ओपन करो कुछ नहीं करना थोड़ा सा हाफ ओपन करना हाफ ओपन बस रुक जाओ चलो ठीक है चलो लो मॉब गॉस पीस नहीं कुछ नहीं चाहिए ये लो, तुम ऐसे पकड़ो थोड़ा हेड लो और कर दीजिए प्लीज यहाँ एपेक्स पे एक्चुअली वी नीड अ बिट ऑफ हेड लो बिकॉज दिस इज एक्चुअली आई हैव टू सी अप पहले हेड लो कर दो सेक्शन कर अभी थोड़ा 30-40 डिग्री हेड लो करना पड़ेगा एट दिस पॉइंट ऑफ टाइम नहीं हेड लो करिए हेड लो
Hemant, there's a question from Shika Sharma. Which
Yes,
are the
sir.
most difficult steps in the operation, the initial stage of learning?
Sir, actually the separation of the rectum, I find it to be very difficult because again, that time actually in the, like in any surgery in the initial case, initial steps, if there is any complication, then it's very difficult to do the procedure nicely. Rest, it's step by step, sir, all steps are important. Okay, very good, very good.
Yeah, I would like to add, if a procedure can be done anatomically with the tissue planes, that becomes very easy, provided you are oriented fully. So the initial part of this dissection is relatively blind and there is no defined tissue plane. So you have to be careful to protect the integrity of the anal canal and rectum, and obviously avoid any injury at this stage.
ये लो सेक्शन करो हाँ चलो काटो तो बस सर आई थिंक वंस वी आइडेंटिफाई द यूरेथ्रा आई कैन सी द यूरेथ्रा ये यूरेथ्रा आ गया ठीक है एक मिनट जरा पकड़ो तो सर आई हैव आइडेंटिफाइड द यूरेथ्रा लाइट थोड़ा फोकस करना होगा इसको फिर तुम्हें छोड़ना पड़ेगा
So this you did in a combined way that you palpated the
Yes, sir.
urethral catheter
Yes, sir. No,
and
you
dissected the surrounding soft tissues.
yes, sir. Yes, sir. So here we एक और दो retractor. So sir, here we have to use a bit of blunt as well as sharp dissection because finger. I think in prostate this ये नहीं चाहिए क्या दे रहे हो? So this okay.
So camera can be adjusted a little better
Yes, sir.
so that you show
clamp
this.
वो दो catheter वो दो. Now, sir, I think now I didn't show the camera. ये पकड़ो ना ये पकड़ो. So I think now you can see the this is the urethra and this is the prostate.
Yes.
And these are the two lobes going.
Yes.
I think it's visible.
Yeah, it is visible. So you will free the urethra from the anterior aspect also. You will.
Yes, sir. Straight artery. I'll free the urethra. I'll make window on both sides. Here. I'll make window on this side.
Hemant, there is a question from Puneet Tiwari. He's asking, are we planning to preserve neurovascular bundle in this patient?
Sir, actually, in this case, I'll just add we have retracted everything laterally. So the neurovascular bundle comes from medial to lateral to medial, and here we have first approached medium, and then we have with the help of retractors we have retracted everything laterally. There is no There is only prostatic parenchyma which is oozing. We cannot see anything. And seminal vesicle also will ligate medially. So everything is retracted laterally. The right angle.
Yeah, for any procedure which tends to present the neurovascular bundle, you should be away from the bundle.
Yes,
There is no need to dissect out the bundle and show it.
Yes, sir.
So same principle is being used.
So this we have done. एक मुझे feeding tube चाहिए होगी, एक right angle दो. So sir, this step is very important because I don't want to injure. बड़ा right angle चाहिए. I don't want to injure urethra at the, like this is the anterior urethra. But we can see this thing.
Yeah.
Are you able to see, sir? This is the anterior urethra. This one. This is the prostate. It's visible.
Yes, this is the urethra at the prostatic apex.
Yes, sir. So when we loop it, I don't want to injure the urethra at the posterior part. Sorry. So this looping is also, I think, it's very important. वो तो मुझे एक मेरे हाथ में दो, फोर्सेप के साथ दो, फोर्सेप लगा के मेरे हाथ में ऐसे पकड़ो, दो बेटा, ऐसे उसकी तरफ फोकस करना, ठीक है. Taking some time for this. Detect करना, उसके बाद detect करना, चलो ठीक है. ये detect करना ना बेटा, तुम नहीं करोगे ऐसे, तुम दिखाओ, इसको ऐसे detect करो, ठीक है ना, ऐसे कर दो, हो गया. Actually, it's a bit thicker urethra is there. Okay. So I think we have looped the urethra. This thing, can you can see all?
Yeah, very clearly seen.
Yeah.
Eman, there's a question from Dr. Santosh. Any modification for post-URP or post-HOLEP patients?
The post-URP and post-HOLEP patient, just I think that the only thing is bladder neck is open, a more wider bladder neck is open. So at the level of bladder neck, there is some problem, but at the level of apex, usually I don't encounter any problem.
And there's another question from Dr. Venugopalan Navy. Is this field of dissection normally bloody, or is it little more oozy in this case today?
Sir, it's little more oozy. I think maybe 10%. It's otherwise well controlled. The reason maybe the patient has biopsy just 3 weeks back. So this I think now I can preserve a bit more of urethra because I can just push the prostate downward.
What is the blood pressure of the patient at this time?
Blood pressure? What is the blood pressure? How much? So sir, it's 150/73.
So that is the reason of the oozing.
Sir, that may be the reason. So you can just give me blade, knife. 115. You
115. Okay.
Okay. So I'll incise the urethra at the level of this section. Karo.
So you use a sharp knife at this stage?
Yes, sir. I don't want to injure urethra because an anastomosis, this is very important.
Yeah, I appreciate that you are not using a diathermy at this stage.
No, sir. Urethra and bladder neck, I avoid using diathermy, sir. Catheter, remove catheter.
So sharp dissection is always better, is preserve the tissue much better.
Yes, sir. So because anastomosis, if the margins are ragged, then the urethra will tear. So that is why I have taken extra time to loop the urethra. The posterior part of the urethra, which we cannot see, should not be damaged. So at this point of time, I'll remove the catheter. The feeding tube is already in place for the posterior urethra, and then I'll cut. करो इसको राउंड करो ना, ताकि आराम से हो रहा है. डिफ्लेट कर दिया, कर दो, आराम से निकालो. एंड यू विल डू दिस. सेक्शन करो, इधर सेक्शन करो. है remove. So catheter is removed. This is the residual urethra and that part which I have cut. So my feeding tube is out. Okay, now give me a straight lousely. Give me a straight lousely. ज़्यादा जल्दी मत लगाया करो. So I have put a straight lousely. I'll open it. Now this, remove this. Now I have to do anterior dissection. So this will, I will give traction. Now, after तुम क्या कर सकते हो? एक मिनट करो. Supreet, now you can just place one retractor only. हमारा urethra का काम हो गया. Now the assistant should not retract urethra. Now only the perineal muscles, because otherwise again urethra will be damaged. So ठीक है. So this this thing is in the prosthetic urethra now, and with the help of traction, I'll do the anterior dissection.
Have you put back the Lawson's retractor?
Yes, a straight lousely.
Straight Lawson. Okay.
Lousely full नहीं है. There's some problem in the bladder neck actually. ये बाहर निकल रहा है.
और straight भी.
ये खराब है.
Holy catheter on do it, Dr. Hemant?
Yes, sir. Sir, I can do, but the initial part I'll just try to do with the lousely, because I just want to depress the prostate. Do harmonic do.
No, I would ask once again, if you put a Foley inside the balloon and just pull it,
sir, I'll do that.
Will it serve the purpose?
Sir, it will not depress the prostate. I just want to depress the entire prostate. So with my left finger, actually I am doing that. Left hand. I'll just tell you, sir. Section though. So retraction. So this is the position of the lousely. These two blades should be horizontal, and then I am depressing the prostate. You're not doing job. Chalo, harmonic.
Hemant, there is a question from Puneet Tiwari. If there is rectal injury, how do you manage? Primary repair or you change the approach?
The primary repair. At the end of the procedure, we can just do primary repair, sir. And no other thing is required, sir. We don't do any diversion. I have seen some injuries. We keep patient NPO for a bit longer time.
Yeah, mostly fresh injuries should heal, and the same approach is used even during robotic retrograde prostatectomy. If accidentally you detect a rectal injury, you just repair it.
Yes, sir.
And hope for the best.
I am just depressing the prostate and I'm so this thing is actually a bit easy in other cases, the anterior dissection. Here there is some additions. I don't know why, but there are some additions.
So this is freeing the prostate from the retropubic fat.
Yes, sir.
So at this stage, your DVC will come.
So DVC actually it will not come. It will go above. Ideally
will
should
fade
not come.
out.
If it's I have done something wrong. So, harmony. I have to take care. I don't cut the prosthetic capsule also, and I should not be close to DVC.
Hemant, there's a question. Why don't you put stay sutures to the urethra before dividing that?
Sir, not required, sir. Sir, at the time of anastomosis, I'll show, sir. It's not required. Plus, that will come in our operative field. So, sir, it's a small space. Whatever extra things we'll apply, it will add to it will create more problem. Because
there's a comment from Dr. Kishore TA. He's telling, do you feel a robotic assistant will be of help in this procedure?
Yes, sir, definitely it will improve. After the initial dissection, robot can come in. The vision will be better. So that is what I feel that if we apply robotic to this procedure at this point of time, because there is a problem of vision. Like after doing so many cases, now we are able to easily do this procedure. There is a bit more oozing as compared to normal in this case. But otherwise, the dissection is going fine. It's only oozing. There is no major bleed again. So I have freed the prostate again.
There's another.
Now I'll change it to Foley's catheter. Foley's catheter. Foley's catheter. एक और Foley's catheter दो. ये भी आप रीअप्लाई करो. Rectal retractor. एक मिनट दो, मैं बनाता हूँ पहले इसमें.
Hemant, there's a question from Dr. Kishore. What about positive margins rate? As it's similar to that of resist sparing prostatectomy?
The positive margin in our series, it is around 10%, and it's usually at the level of surprisingly, it is at the level of prostatic apex, never at any other place. We maybe said the reason is we do a bit of handling in the form of Lowsley tractor, so that damages our apex. So the reports they report at positive because some handling is there at the level of apex. इसको ड्राई कर देते हैं. ठीक है, ऊपर उठा के रखा तुमने, नीचे का रिट्रैक्टर दो.
There's a comment by Dr. Rajiv Sood that the Turkish surgeons use Foley rather than the straight Lowsley.
No. Yes, sir. The Dr. Salami Albrak is there. Actually, we inquired from him whether he has a Lowsley, because we were not able to procure Lowsley anywhere. So we asked Dr. Keller, Dr. Salami, if there is a place where we can procure Lowsley. So he told that the Dr. Salami that he does not use Lowsley in any of his case. So now I just मुझे एक बार और देना saline. So I have now put catheter. With my finger, I'll try to feel the bladder neck. Okay. Inflated with 15 ml. ये तो हटाओ.
Finger with rectum in the rectum?
No, sir. Here, because sir, like this you can see here.
Okay.
This is the bladder neck.
Dissected the.
Yes,
okay,
sir.
Dissected the base of the prostate.
Yes,
and
sir.
inserting a balloon in the bladder and filling that balloon.
Yes, sir. So this is the bladder neck cautery. The bladder neck fibers I'll incise with cautery. Cautery section करते हैं. लाइट थोड़ा सा कम है. Cautery, वो हार्मोनिक. लाइट कम है. So central, I have separated the prostate from the bladder, and the lateral part I am doing it with cautery. So here you can see the bladder neck fibers,
No,
the
it's
circular bladder
not
neck fibers.
clear. It's the camera. The camera
So
is.
Yeah, adjust the
I'll
camera.
just show, sir. I'll just show. So
Yeah, show these at this stage so that the students have a good impression.
So I'll just show, sir. So this is the prostatic apex. This we can see. See, I have depressed, and this is the bladder neck fibers. Can you see?
Yeah.
Here you can
Appreciate.
see. So these are the circular bladder neck fibers here. These are circular bladder neck fibers. Okay, and this is the prostatic part. We'll encounter urethra somewhere here. Sorry. So the cautery harmonic. Only the bladder fibers that I incise with harmonic. Harmonic. I think now you can see the this part, the prostate and entire prostate we have depressed.
Now we can appreciate the junction very clearly.
So we'll try to preserve bladder neck fibers. Again, we are a bit slow here because we want to preserve bladder neck fiber. We don't want to open it very big. No harmonic. So again, the urethra part I'll open with the knife, and the circular fibers, like other procedure we cut with energy sources, we'll cut it in that way only. Section. Section करो यार. Loop दो, loop, right angle. Right angle. I'll try to ब्रो काट दो कॉटरी से काटते हैं. I don't know urethra. काटो कॉटरी से काटो. ये सेक्शन करते रहिए ना, कॉटरी से काटो. Sir, I think sir, this we can see, we have preserved the entire bladder neck, the circular fibers. So harmonic. Section करो.
Dr. Hemant.
Yes, sir.
Why don't you cut simply with scissor?
Sir, I am a bit patient here. Right angle.
That part is fine.
I
Because
don't want to. Sir, actually, I have cut the urethra inadvertently. Cut. सीधे से काट दो कोई बात नहीं. सीधे काट के किसी से भी. Actually, bladder neck has been opened now. Otherwise, I always try to loop the bladder neck. So, मुझे दो right angle दो. So in this case, it was not possible. So यहाँ पर section करो.
so you try to loop the urethra of the bladder neck.
Yes, sir, I try, but here this time it was not successful. ये करो, catheter deflate करो. So now, sir, this is the bladder neck, and I'll just loop the urethra so that for a better traction. Deflate कर दो और एक और catheter खोल देना. पुल मत करना. हो गया पूरा.
एक बड़ी आर्टरी है.
सेक्शन कर लो जब तक. सेक्शन कर लो.
हाँ.
So sir, here generally after cutting the bladder neck, we were looping the urethra, so that is why I was a bit more patient. Low karo. छोड़ो. So sir, we have looped the this is the prostate anterior part. Now we can see the posterior wall of the urethra, right angle. This is the posterior urethra. What we can see, the section करते रहो. This part we will cut this. Cut करो और सीधे से कट करो आराम से कट करना. ऊपर नहीं. हाँ चलो एक वो दो मुझे कैथेटर. एक और कैथेटर दो. फोर्सेप दे दो. एक फोर्सेप चले.
Camera has to be focused.
Focus. Camera focus करो. Sir, this is the open bladder neck. You can appreciate.
Yes.
This is the bladder neck we have opened. Catheter. क्या करो छोटे का. हाँ. Now inflate करो. So we have put one catheter around the prostate and one in the bladder neck for a proximal traction. So we'll remove this retractor. He'll just retract it upwards. 15 ml, 15 and 20 ml. बाहर आ जाएगा ना catheter. Proximal वाला lumen तो ज़्यादा है ना. 20. Hopefully it should stay. Yeah. So तुम ये पकड़ो. बहुत ज़्यादा मत पुल करना. ठीक है. ये लो. इसको तुम हटा सकते हो भी. इसको ऐसे लगा लो भी. ठीक है. नहीं इसको लगा लो ऐसे. बस for demonstration ना. ठीक है. So now sir, now again दो हार्मोनिक दो. दो. मुझे आवर देना. राइट एंगल. और हार्मोनिक ले लो आप। क्या हो रहा है? थोड़ा सा है, संकल है वो। दे दो हार्मोनिक दे दो। सेक्शन कर लो, सेक्शन कर लो, सेक्शन में। So normally, sir, posterior planes are a bit better,
Yes.
but here there are some additions which is making it a bit difficult. Otherwise, with just finger, we were able to separate. We were able to have a good plane. You see the
Yeah,
right
you
angle.
get
Right.
the vast difference now.
Yes, sir. Sir, after we incise the posterior wall of the bladder, but
Bladder, yes.
it is there are some additions with posterior wall of bladder.
Mhm.
Cotry. Simple cotry. Again, I have to go a bit down so that I incise the entire posterior wall. Harmonic. Section लगाओ. राइट एंगल ऊपर पुल करो ऐसा करो. कॉटन. राइट एंगल हार्मोनिक. सेक्शन कर.
Hemant, is this plane difficult today, or is this?
Sir, it's a bit difficult today. It's a bit difficult today because normally this plane is very easy to make, the posterior part of the bladder. But it's a bit difficult. It's more oozy also, and the exact plane is a bit difficult, sir. But normally it's the easiest part of the surgery. The all difficult steps actually we have done. There are some additions at the level of bladder neck posteriorly. Maybe biopsy related. It's biopsy related changes. Otherwise, with just finger dissection, we always we were able to make the plane between the prostate and the rectum. The bladder and the rectum actually. Now I think we are to the plane. No, right angle. वो है एक्चुअली यहाँ पर ना रेशंस आ रही है. This is normally this part is very mobile, the posterior bladder wall. This time it's cutting. So मुझे वो तो ये दीवार पतला दीवार छोड़ो तुम छोड़ो. So I have separated the posterior bladder wall and I'll just छोड़ो retract करो ऊपर की तरफ. Okay. Addition normally ये addition normally इधर कोई addition बाकी नहीं है. तो मुझे हार्मोनिक लाइट फोकस कर दो. ओके तो ये तो हार्मोनिक
Camera has to change. This position is not.
वो आपको मुझे दो दूसरा डीवर दो बड़ा वाला. So you can see there are a lot of additions posterior aspect of the bladder.
Yeah. Yeah.
This plane is not version. Normally, this part is the easiest part. Like we do in open radical prostatectomy, once we have inside the posterior bladder neck, we just elevate the posterior part of the bladder. So what this we have done, but this actually area is not very a bit difficult. Do right angle. Some addition.
Dr. Hemant, you have freed the posterior surface of the prostate
Yes,
from the bladder during the initial part of your dissection.
Yes,
so
sir.
would a palpating finger help you?
That will help. I'll if I'm not able to proceed from here, then I'll do that, sir. So actually I can do that. So just remove it. Posterior वो दिखाओ posterior वाला retractor. ये पकड़ना malleable retractor. पकड़ो. पकड़ो. Harmonic. Actually, we can see VAS now. थोड़ा हेड लो करो, हेड लो करो. ये राइट एंगल सेक्शन करते हैं ना. बड़ा वाला राइट एंगल दोगे.
The question from Dr. Ajay Sharma: what is the learning curve for this surgery? What is the number of surgeries you have to do?
Sir, basically we started from day one. We have observed surgery. I think I have observed 10 to 12 surgeries. Then I started. Now this is a bit. If you are stuck, it's a bit difficult case. But otherwise, if you observe sir, 3-4 surgeries, you can do. The retractor, malleable retractor. Because they are not very complicated step. Only thing is there is like now the entire part was okay, but the posterior bladder neck is giving problem. The harmonic. The posterior dissection went well. The apical dissection went well. Harmonic. But I am able to do from the posterior side. आगे से करना पड़ेगा. करना तो आगे से पड़ेगा. मुझे राइट एंगल दो. What I am doing is I am just looping the. यहाँ से उधर रखो. ये फुलिस क्या तरह नहीं. एक और फुलिस ये निकाल दो. ये वाला फुलिस निकाल दो. हाँ ये निकाल दो. निकालो. यहाँ पर दो. दिख रहा है? What I am doing, I am just looping the this Foley's catheter all around the urethra.
They actually, yeah.
So okay.
Camera should show it better. Camera should show the better.
Now, yeah. So now what we have done is we have actually put the catheter all around the prostate, in the midline, not only through the so we will be able to better identify the. Now we can see the vas also. वो दिखाओ loop नहीं डीवर बड़ा डीवर दो. नहीं इतना बड़ा नहीं है. हाँ ये वाला ठीक है सर. नाउ इट विल बी बेटर सीन. हाँ बस ये देखा सेक्शन करो. नाउ यू कैन सी द वास. ठीक है. नहीं बेटा ये नहीं. पतला वाला ले लो. पतला वाला ले लो. तुम ये नहीं कर पा रहे. बस एक मिनट. ये लो पकड़ा.
The PV Srinivasan is asking, do you do intra-op frozen study for positive margins?
Well, just this is. I think now we are into a this vas we can see. You can see the vas.
Yes, it is appreciated.
One side vas and seminal vesicle we can see.
Left side vas and seminal vesicle.
So actually this plane we wanted, but there was some addition at the posterior wall of the bladder. So which actually spoiled the procedure a bit. Right angle.
No, it's okay. You know, all case will not be textbook case.
Yeah,
that's important.
Section करते हैं. So sir, I think the patient left vas and left seminal vesicle. We can see. Gradually we'll see the right vas and right seminal vesicle also. So by section I'm just separating, making things comfortable for me. Right angle. this is the vase, one side vase. Clip though. Can everybody see? I think
this is the ample of vase.
Yeah. So give me a hemlock or something. Retract karo, so please retract karo beta. So we have applied a hemlock. One more hemlock. ये apply नहीं हो रहा. दूसरा.
It's not applied.
So almost we are at the now when we identify the second vase, now it's only right angle connected with vase and seminal vesicle. Nothing else is there. So once we like it, both vase and seminal vesicle, our specimen will be out. Look. We can actually do it without clipping also. We can remove it. इतना छोटा hemlock दे रहा हूँ. दो सीधे दो. So we have located one-sided vase. This is the vase we can see. Okay. So section. No, one. This is the seminal vesicle. There's some fibrous strand. We'll just try to dissect the seminal vesicle from here. Harmonic. This part we will have to cut because ठीक है. Some ये give me section. So this is the entire seminal vesicle. We have dissected. Generally in renal prostatectomy we so now we are in a comfortable plane because now our dever actually has gone in the right place. Now it's completely elevating the bladder, posterior bladder. This plane was a bit difficult. That is why we were struggling. So harmonic though, harmonic though. So whatever the attachments that we will have to take, we have to incise because then only we can remove the specimen. Section. So with the help of section, we can just divide the, we can deliver our seminal vesicle. If we loop it, generally it's tears. The right angle. Cutting. Cautery से काटो. Cautery. Can you see this? Small vessel. No, काटो. बस पीछे seminal vesicle है. Don't. ठीक. So. Section. So this the entire seminal vesicle one side we can see. The same thing we'll do on the opposite side. This we can see this is the rectum posterior. So here also we can see the this thing vas. Harmony. Bit more than expected additions are definitely there. Though harmony though. So this is बटन बंद बंद करो तो फिर कैसे है so we can see the this thing was seminal vesicle on the opposite side. बड़ा रिट्रैक्टर लेना बड़ा चौड़ा रिट्रैक्टर लो हाँ मैलेबल ऊपर दे दो ऐसा करो मैलेबल ऊपर दे दो आई थिंक मैलेबल से ज़्यादा फायदा होगा निकालना बंद करना पकड़ पाए सफेद you can see the vase on this side again. This is the vase and it's a bit stuck up with the seminal vesicle. I'll just loop the vase. वो दो right angle दो right angle section करते रहना. So this is our vase. But the vase and seminal vesicle are coming together. The right angle दो focus दो. So this is the second vase. Thing it's visible.
Yes. Yeah, very clear.
So give me the clip, hemlock clip. इसको हटाओ चलिए बात करो हाँ give me the clip. I just oh sorry बड़ी दो थोड़ा बड़ा दो है ना मोटी आवाज पकड़ो थोड़ा डिसाइड कर लेते हैं
Is clipping the vase essential, Dr. Hemant?
yes sir
Is clipping the vase essential?
Sir, just for the demonstration. So this is the vase. What we
Yeah,
I just
there
wanted
may
to
be
show.
small vessel you are
Yes.
taking care of that. Otherwise, you can cut with that also.
Yes, sir. We can do that. Caesar. So this is the second vase we have cut on the right side of the patient, our left side and the right side of the patient. This is again, this is seminal vesicle. Some additions are there, which were actually there was some element of prostatitis also. This patient, the patient was symptomatic. We have done repeated culture. The culture was never positive. Harmonic बंद है? I think that is the prostatitis. हो गया सही? Prostatitis element that that is why there was a bit more oozing in this case. यदि ऑन रह जाता है, हार्मोनिक का हैंडल चेंज करिए. जो ले रहे हैं बंद तो करो हार्मोनिक. जो करना करो. So I think we can see the opposite side. I think this is visible now. This is the second vase, seminal vesicle here, vase. Now the second seminal vesicle on the right side. It's visible.
Yeah, I appreciate. Actually,
Right angle.
your hand is coming on the way.
So I'll just
So the
show.
camera can be adjusted so that shows.
Give me
That's better.
It's better, sir, now.
Yes.
So forceps. You retract. ठीक है. So we can see the left vase, left seminal vesicle, left vase, right vase. This is the right seminal vesicle. Once this is out, right angle. Suction करो. So, a specimen will be out. Last, I was a bit less patient here now. Again, that is why I have gone inside the vase, seminal vesicle. Cut करो. Some final attachments are there. नीचे मतलब. तो सेक्शन दो मुझे. सेक्शन. दो वो दो आर्टरी कुछ दो. लैटरल अटैचमेंट आर्टरी दो जल्दी. और हार्मोनिक रेडी रखना. हार्मोनिक रेडी नहीं है. तो मैं बोल रहा हूँ नया ले लो हार्मोनिक. आप इतना टाइम क्यों लगा रहे हो? अभी तो चाहिए 2 मिनट के लिए मुझे हार्मोनिक. आया कि नहीं आया? मुझे अभी चाहिए था ना. करो चलो कोई बात नहीं. आगे दो कॉटरी दो. फिर राइट एंगल दो. कॉटरी दो. फुट स्पेस से दे दो. कोई बात नहीं. कुछ जो भी चल रहा है दे दो. इस जगह पे थोड़ा सा चाहिए मुझे. हो रहा है हार्मोनिक. करो कंटिन्यू. लास्ट स्टेप नहीं तो नहीं आता है. There's some problem in harmonic. I'll just wait for 1 minute. हो गया? ठीक है. हो गया ना? ठीक है. तुम करो मैंने. ठीक है. सेक्शन. Left side is a bit stuck up. दो हार्मोनिक. ठीक, right angle. ठीक. We have separated actually from the front. We have separated all the seminal vesicles, vas, and this is a small fibrotic seminal vesicle also that we have separated. Now from the back we'll just थोड़ा सा हाइट लो कर दो, हाइट बहुत ज्यादा है, मैं ज्यादा नहीं देख पा रहा अंदर, हाइट डाउन कर दो, टेबल डाउन थोड़ा सा, हाँ करो बस, ठीक है, चलो कर दो, मैलिबल छोड़ो, ये पकड़ो, हार्मोनी एक्शन कर लेना. These are some flimsy connections which are remaining.
Yes.
From both sides. Otherwise, everything is out. Rectum is already behind, so we'll just remove it.
Dr. Hemant, have you done perineal prostatectomy for benign prostates?
No, sir. We've actually done only for malignant prostate.
Because originally young did it from benign prostate, you know.
Yes, sir. But sir, somehow I feel that URP is we have very good procedures.
That's an easy procedure, no doubt about it. That's an easy procedure.
And this is a bit difficult, so
yeah,
we reserve it for only. कोई बात नहीं, चल रहा है ना, चलने दो. There, the only problem was there were some adhesions which were that, but I think
in
now
a case to case you will expect.
But now
Post biopsy many times
section.
bleeding occurs, hematoma occurs, so
yes,
those lead to these kind of things, situations.
So we are just close to the prostate and we are taking care of all the. हमारा यार ये चले जा रहा है, तुम नया कनेक्ट कर दिया, काम ही नहीं कर रहे, करो चेंज करो, काम नहीं कर रहा, तुम क्या कर रहे हो, ऐसा करो, तुम ना ठीक है. बैठो बेटा, वो रखा अपना ट्रैक्टर ले, अपना ट्रैक्टर ले ऊपर ना, नहीं वो नहीं, रिवर्स हार्मोनिक. यहाँ से काट Harmony. Action. प्रोस्टेट पीछे से बहुत चिपका हुआ है. दो हार्मोनियम. रेक्टम पीछे दिया हुआ है ना. There are a lot of adhesions.
Following biopsy on this particular patient, was there any problem?
So they was having some dysuria, but the culture were always negative. Actually, when we decided, we thought ki it is because we had only this case. There was some element of prostatitis, sir, actually. In biopsy also, there was 5 out of 12 code positive. Rest were showing prostatitis. But though harmonic though. Now it's almost done. So that is what I'm a bit, again, we have to be always careful about the rectum. So
surely.
Almost done, almost done. Okay. Now it's completed. Okay. This part is removed. No. I think we can see the adhesions with the rectum. No, no. Hello? This is. This last. This part. Okay. So this is the mouth. Mop do. Think so. We have removed the entire prostate. Mop है कुछ भी दे दो बहुत please. Just keep it here.
Yeah, you can show the specimen to
Yeah.
the audience.
So sir, this is the entire prostate. This part was a bit difficult. The orientation was like this. Actually like this. Catheter दो एक बार.
That's the posterior surface you are showing.
Yeah, this is the anterior
that-
surface. This was the anterior
Okay.
surface, sir. The prostate was like this.
Yes. Yes.
This was the anterior surface. So first we have approached this place. Then we have done the
Yes.
posterior dissection. There was a lot of forceps. There was a lot of prostatitis element over this place. We can see it a bit fibrotic. So normally they are good planes. We can see both the vas, right and left vas, and this is both the vas and seminal vesicles. So this is the entire posterior surface of the prostate. This is the apex of the urethra, and this is the small anterior compartment. And then again here was the bladder neck. Again the bladder neck was there were some fibrotic changes present there. And then this is the posterior part.
Do you feel the nodules on the surface of the prostate? Because on DRE, this patient had a nodule on the right lobe.
Yes, sir. I can feel it on the right side here. Sorry. On the right side,
Just
I can
focus
feel a
on the
nodule.
camera. So that,
Here I can feel a nodule, sir. Here, this finger. This
Okay.
right mid part, I can feel a nodule. You can also feel. No. So right mid part, I can feel a nodule. This part, and rest of the prostate, I'm not able to feel anything. Here on DRE also on the right mid part, there was a nodule. This was clear kar do. Now we'll start with the anastomosis part. So I think now there is no bleeding. After removal of the prostate, there will be no bleeding from anywhere. Only the urine will come. So I don't know why. Though with the divorce. हाँ malleable. और एक mop. एक mop दो. Forceps. So this is the posterior part. No, malleable retractor, beta. ठीक है. So we can see पकड़ो यार यहाँ पर आओ. ये पकड़ो. ये छोड़ दो ये मुझे दो. मेरी फील्ड में दो. छोड़ो उसको. छोड़ो. ठीक है. अब give me a Langenbeck. सिंगल लोग retractor दो. Okay. So I think you can see the open bladder neck. वो तो मुझे.
Yes, it is seen. The posterior bladder wall is quite thick and.
Yes, sir, because of the fibrotic change.
That is the fibrotic changes.
But otherwise, it's bladder only.
Yeah.
Because we can see the bladder neck fiber here.
Bladder is a muscular organ, Bladder is a muscular organ.
दो. वो दे दो मुझे forceps. और syringe दो syringe. खाली syringe मुझे catheter निकालना है. वो दे देना 4 या 3 cutting needle पे 3 दे देना.
So in this case, there is no need of closing the bladder neck because the bladder neck is quite.
Sir, I'll just put a forceps and I'll see. Because this is, I don't think there is a need. I'll just open the forceps section. No? So this is the bladder neck, but we can see this much.
Yes.
So once we close, there is almost no urine coming. When we open it, so this is the bladder. So we don't need to close it.
Yes.
And we don't need to. I don't think we need to examine the inside of the bladder also. The urine is coming. Normally we don't do cystoscopy. Okay, sir, it's visible.
Yeah, it's visible.
Yeah. So sir, this part, so this part.
Show the proximal end of the anterior.
Yes, sir, I'll show. So this is the posterior part of the bladder, and it is a bit like adhesions are there. Some adhesions are there. We can take extra chip from there, but I don't feel we have left any prostate at level of bladder neck. Anterior also the bladder neck fibers we can see. For
you have shown the specimen, the prostate has come all the
yes, put a catheter from upside. अब ऊपर 2 लोग चले जाओ, एक जना रिट्रैक्ट करेगा सर. व्हेन वी डू सर दिस रिट्रैक्शन ना, वी शुड ओनली रिट्रैक्ट द ट्रांसवर्स पेरिनेम मसल्स, नॉट द यूरेथ्रा पार्ट. तुम
Sure.
डालो कैथेटर डालो, तुम कैथेटर डालो. तुम ये बेटा ये छोड़, तुम कैथेटर बाद में चेक कर लेना. कैथेटर तो बाद में रहेगा, अभी अच्छा एनास्टोमोसिस के लिए चाहिए मुझे. अब इसे प्रॉक्सिमल यूरेथ्रा दिखाना है. For 3O vicryl cutting, okay. Now this will take at least I think another 5 minutes for anastomosis. हाँ एक पकड़ो, अब ये पकड़ बेटा, ये पकड़, एक हाथ से पकड़, एक हाथ से आगे पीछे करना है, बस इतना पकड़ना है, ठीक है. थोड़ा हेड लो चाहिए मुझे. तुम अंदर कहाँ जा रहे हो? मतलब नहीं ऐसे मत करना. तो दो कैथेटर लो, एक जन और जाओ पर. पकड़ो, एक और दो लैंगन बैग पकड़ो, खींच के रखना. ऊपर कैथेटर पकड़ के रखना, पकड़ा मैं कितना टेस्ट. और हेड लो करो, हेड लो, इसमें ज्यादा हेड लो होगा अगर यूरेथ्रा देखना तो. हेड लो, पूरा हेड लो करो, शोल्डर सपोर्ट है ना. हेड लो करो, और करो, हेड लो. मैक्सिमम
Yeah,
नहीं है,
adjust the
और हो
camera
जाएगा.
also in this.
हेड लो करो. अरे होगा, कैसे नहीं होगा, और होगा. ठीक है, अब थोड़ा हाइट का, हाँ ठीक है, बेटर है. बेटा एक मिनट छोड़ो, तुम्हें रखना है, तुम मत छोड़ो, तुम्हें नहीं छोड़ूंगा.
So this head low is how much? 30° or 40°?
आई थिंक 40. कितना, हाउ मच? ये ऐसे रखो, ऐसे रखो सर. जिससे एक्चुअली आई कैन डू विदाउट दिस ऑल्सो, बट
No.
टू शो.
It's important to see the stump of the urethra.
यस. तो सर
That's
आई
what you are
थिंक,
doing it.
हाँ सर, दिस इज द यूरेथ्रा सर, दिस पार्ट. कैथेटर को थोड़ा पीछे लो, पीछे लो.
Yeah, you can proceed with the
वंस वी टेक,
anesthesia. Yes.
हाँ जस्ट और पीछे करो, थोड़ा और पीछे करो, 1 सेंटीमीटर, 1 सेंटीमीटर पुल करो बस. अब इतना नहीं बेटा, डालो डालो. So this is the urethra, you can see sir.
Yes.
Just it's coming out of the urethra,
Yes.
this part. So normally it retracts, so we have to retract the muscles. Once we take one suture, then it will come down. So I think it's visible.
Yes, very clearly visible.
Okay sir, okay. दो suture दो, बस ऐसे पकड़ना. फोर्सेप्स कुछ है, कटिंग है ना, तो सेक्शन.
You are using a V lock or a?
Sir, I'm using a simple vicryl 3-yoke on cutting.
Okay.
फोर्सेप मुझे मोटा वाला दो फोर्सेप, ये इंजर करेगा मेरे को लगा. Take this one. Little holder. We have taken a 2 o'clock suture first, just for retraction. एक और दे दो मुझे suture, मुझे ट्रे दो. So this is our first suture just for the retraction. यहाँ दो mosquito.
You will use interrupted or you will use a continuous?
Sir, we can do interrupted or continuous both. I'll do interrupted this time. It will better demonstrate actually. So we can do any. We can do even this thing. आपका needle holder ठीक नहीं है. This is the 12 o'clock question. Okay. आ गया. So this is 12 o'clock.
Yes.
चलो अपना वो दिखाओ मुझे. एक मिनट आपका हेडलो कर रखा है. नहीं एक बेटा बेटा एक मिनट सुप्रीत. हाँ बस ऐसे दिखाओ. सुप्रीत ये पकड़ा हुआ है. आप कैथेटर पीछे करो. तुम यार इसको ना तुम अपना काम करो ऐसे. ठीक है. नाउ द फर्स्ट सुचर इज वी कैन सी द कैथेटर.
Yes.
You can see the catheter. Just push it. पुश करो थोड़ा कैथेटर को. थोड़ा सा पुश करो. हाँ और पुश करो. करो पुश 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 करो. दिखाना है. पुश करो थोड़ा सा. हो रहा है पुश आराम से. बस ठीक है. अब धीरे धीरे विड्रॉ करो. विड्रॉ करो. विड्रॉ करो. विड्रॉ करो. विड्रॉ कर बेटा. विड्रॉ कर. 1-2 सेंटीमीटर विड्रॉ कर. विड्रॉ करो. विड्रॉ 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 विड्रॉ. एक मिनट पकड़ो. मुझे फिंगर डालो कैथेटर. डालो कैथेटर. डाल लो बेटा.
Hemant, this was the reason why people were asking whether your stay sutures at up front before transacting, that would help.
Sir, actually that will not help because I'll just that suture if they break during the procedure because we have to manipulate a lot. Push करो ना. डालो ना. So sir, if they break, they will tear the urethra, and then suturing will become difficult. It is not actually that difficult. थोड़ा डालो कैथेटर. क्या कर रहे हो? इतना मत पुल करो. 1 सेंटीमीटर आगे 1 सेंटीमीटर पीछे बस. बस बस अब पूरा दिखाई दे रहा है. अब तुम ये पकड़ो. ये इसको रिट्रैक्ट करो. इसको रिट्रैक्ट करो ऊपर की तरफ. कर रहे हो?
He is trying to see the mucosa. He is
अब
taking
फोर्सेप.
it around.
फोर्सेप. और मुझे एक वो दे दो. मुझे मॉस्किटो दो. मुझे इसको और कर्व करना है. आपने मुझे कम कर्व नीडल दी है. बस ऐसे ही रखना. लो पकड़ो. चलो बेटा तुम अपना ऐसे रख. अगर ऐसे रखेगा तो मेरी तरफ देखेगा है ना. पुल करना पड़ेगा थोड़ा. लो फोर्सेप. अब पुश अब करो. अब तुम मत करो पुश. Can just pull this catheter. I can take the posterior wall easily. पुल कर लो कैथेटर. कर लो. तो ठीक है. सेक्शन दो. सेक्शन दो.
So this is your 12 o'clock suture.
It's yes sir.
Yeah, knot will be outside. Okay.
Sir, we knot is outside.
Yes.
I'll just tie it. थोड़ा रिलैक्स करो. सब लोग थोड़ा रिलैक्स करो. फोर्सेप दो. फोर्सेप. तुम रिलैक्स करो. छोड़ दो. तुम छोड़ दो. दो मॉस्किटो, दो एक और सूचर दो। अब रखो ऐसे। अच्छा, तो तुम अंदर मत डालना है, ठीक है? तो प्लीज कैथेटर करो, पीछे करो। दो मुझे। We have taken लो पकड़ो। Both posterior sutures we have taken. कोई बात
This is your second suture.
नहीं। Yes sir, थोड़ा सा छोड़ दो। Both will come outside.
Yeah.
Somehow some problem. देखो कुछ गड़बड़ हो गया है। ठीक है, ठीक है। Very good. करो। ठीक है। कैथेटर डालो एक बार, तो आराम से आ रहा है कि नहीं। ठीक है, कैथेटर इज कमिंग। सीधे काट दो, दोनों सूचर काट दो। डेविड सीधर सीधर, ये लो, ये पकड़ो, मुझे यही सूचर दे देना चाहिए। तो सर वी हैव टेकन 2 posterior sutures and
Yes.
at सीधर सीधर, ये लो पकड़ो। ठीक है, पकड़ो पकड़ो, निडल होल्डर में दो निडल। Now we have taken this suture we have already taken, the 3 o'clock suture. This is outside and give out needle holder है मेरे पास needle। ठीक है बेटा, ठीक है, ठीक है, अब जरूरत नहीं है इसकी। दिखाओ तो मेरे अटैक करो बेटा, तो प्लीज बस ऐसे, और कुछ नहीं करो, पीछे करो करो। बस we can see the urethra inside. We'll just go inside there and rotate. Hmm. 3 o'clock suture we have taken. सूचर कौन से ये रोल क्यों नहीं हो रहे ठीक से, आगे तक नहीं जा रहे ठीक से, पता नहीं, मजा नहीं आ रहा। ऐसा लग रहा है सूचर नॉट आगे अंदर तक नहीं जा रही। तो सीधे दो, ये लो पकड़ो, द फोर्सेप्स और सूचर। दो suture forceps. We'll take a posterior suture, mucosa we can see. No. These sutures are very important, the posterior sutures, because here the urethra, if there is any leakage, it will be from the posterior side. So थोड़ा सा कैथेटर डालो, हाँ वापस लो, यहाँ करो वापस कैथेटर अंदर करो, अंदर करो. We can see we have gone inside and it will come from here. So this is the dependent part of the anastomosis. So these sutures are very important. I'll just place all three sutures and then I will tie. Otherwise, if I tie these sutures, then it will be difficult to take further sutures. So this is my almost 4 o'clock suture. एक और दो. This is the 6 o'clock. ये नीचे करो, इसको रोटेट करो. This is 7 or 8 o'clock suture. Take it from the urethra. urethra catheter पीछे करो, थोड़ा थोड़ा. ये नीचे करना बेटा, तुम क्यों छोड़ देते हो. चलो करो करो करो, पीछे करो. नया कैथेटर डाल देना, डालने के लिए. So you can see we have gone inside the urethra. This is the lateral part. Just we have to take 6 o'clock suture now. छोटा कैथेटर सुचर मत दिया करो, फुल लेंथ सुचर दिया करो. मॉस्किटो दो, एक और सुचर, लास्ट सुचर. किलो ने लोड लास्ट सुचर दो. कलर ये को कलर चेंज हो गया ना. अभी कैथेटर नया ले लो. वी आर टेकिंग 6 o'clock सुचर. बेटा इसको ड्रेस करना, मुझे स्पेस चाहिए. ठीक है, छोड़ दो, अब तुम रिलैक्स हो जाओ. दिस इज द लास्ट सुचर. चलो कहते वो दिखाओ, इसको और थोड़ा रिपीट लास्ट टाइम बेटा, आराम से. हाँ, here we should not take this transverse perineal muscles, so that is why. चलो करो कैथेटर पीछे, कोई बात नहीं, बिल्कुल दिख रहा है यूरेथ्रा बहुत अच्छे से. बेटा वो छोड़ो, अपना रिट्रैक्ट हटाओ, तो प्लीज वहां से आएगी नेडल. हाँ पीछे करो, बस ठीक है, ठीक है, डन. कैथेटर डाल दो. So we have taken posterior sutures, knotting we have done, anterior sutures, all stay sutures we have taken, these three. Now we'll put the catheter and we'll do the final anastomosis. दो डालो कैथेटर, डालो. नहीं रुक जाओ, मुझे फोर्सेप दो. हाँ डालो, अब डालो, डालो. चला गया, गया. So we can see the catheter is inside. This we can see.
Yes.
Yeah. So just we have to complete the anastomosis now. ये पकड़ो, इन्फ्लेट कर लो. नॉट जा रही पूरी अंदर, नहीं क्यों. देखो है ना फाइनल कुछ कैथेटर कुछ स्विचर में प्रॉब्लम है क्या? स्विचर में प्रॉब्लम है क्या? ये छोड़ना, तुम भी छोड़ो अपना रिट्रैक्टर, तुम भी छोड़ो, ये छोड़, बाहर निकाल दो रिट्रैक्टर, रिट्रैक्टर बाहर निकाल दो। ये नॉट पूरी प्रोसीड नहीं हो रही। स्विचर कौन से? स्विचर पूरे नॉट आगे तक नहीं जा रही मेरी। ठीक है अब चलिए। नहीं वो लोकल स्विचर है कोई। ठीक है सीजर सीजर काटो काटो काटो, ये लो पकड़ो। यही स्विचर देते हैं ना पहले, ये कोविडियन वाले। ये देखो
This
ये
is
पूरा जा रहा
monocreel or what?
है सर। दिस इज मोनो वाइक्रिल रैपिड ना, वाइक्रिल वाइक्रिल, दिस इज कोविडियन स्विचर सर।
Okay.
on cutting needle.
Yeah, cutting needle and your curvature is, I think, 2/5 of the circumference.
Yes sir, yes sir. So sir, that as per need we can cover it more or less. So
No, it is important because you have gone through the thick bladder neck.
yes sir. This is our final suture.
The anastomosis appeared quite easy.
Yes sir. And it is with the prosthetic urethra and the bladder, because we have mobilized the part of bladder, so this thing easily there is any tearing of the suture or the urethra. Bladder is mobilized, so bladder will come down, the urethra will not go up.
Yeah.
So this is
Do you do any kind of reinforcement, like the kind of Rocco stitch in
sir, it is not,
retropubic?
sir, it is not required because we have mobilized the
Not
bladder.
required. Two are coming, ends are coming quite easily.
You can see we can mobilize the bladder very till almost till the bladder apex, bladder dome. So it can easily come. There is no tension on the anastomosis. You can see this is the urethra here, and this is the anastomosis. So there is no tension on the anastomosis, and the rectum, everything is intact. So that is the.
Yeah, good job. And within 2 hours, you started at 10 o'clock. 2 hours and 10 minutes.
But I think the bladder neck part was not that clear. So
that's fine. That's fine.
So we'll just remove this retractor. We'll do washing. Wash kar do ek baar. We can see the anastomosis. This is the anastomosis. Sir, about the reinforcement. Sometimes if the posterior bladder walls are nice, मुझे एक मिनट single malleable retractor. So about the sir, if ये पकड़ो malleable retractor पकड़ो. So sometimes what happens is this posterior bladder is very healthy. So what we do, we take a second, we do mucosa to mucosa anastomosis. In this case, actually we have taken the entire posterior wall and urethra, but we do mucosa to urethra anastomosis, and the rest of the bladder wall we reinforce with the transverse perineal muscles for additional strength. So, but in this case it is not required because this is a bit fibrotic. If I take suture from there, it will tear. So nothing else I'll do. I'll just anastomosis is there. I'll put a drain and I'll close because we have not cut any muscle, only soft tissue. So we'll just suture this part from this part and then we'll close the wound.
So we'll approximate the soft tissue and then close the skin.
Yes, sir. Because we have not cut any muscle. We have all retracted all the muscles. Only rectourethralis muscle was cut, and suturing is not required that much. Though,
yes. You leave a drain?
Yes, sir. I'll always leave a drain.
Okay.
How long you keep
the?
That for 2 days.
How long you keep the urethral catheter?
मुझे एक mop दो. The urethral catheter can be for around 10 days. Like maximum we keep for 14 days, but the in this I'll keep around 14 days, sir.
Do you do any kind of dye? Do you do any kind of dye study before removing the catheter?
No, sir. No, sir. Routinely we just remove the catheter. There has been never any incidence of leakage. So that there is complete anastomosis, so complete hemostasis.
Very nice.
forceps देना, forceps, तो कॉटरी कर दो. Okay, so I'll put a drain. दो, drain दे दो.
ट्रेन दे दो.
Hemant, there's a question. What is the incidence of incontinence?
Sir, incontinence, generally there is grade 1 or grade 2 incontinence at the time of catheter removal, but at around 2 to 3 weeks, either there is no incontinence or there is grade 1 SUI. The continent patient is very much continent. Like in entire 40 patient, there is I think only one patient who is grade 3 SUI, and that patient had actually fistula leakage, urinary leakage. Third patient, that he is having grade 3 SUI till now. There is no fistula now. We have repaired that, and none of the other patient has grade 3 SUI. It's maximum they have grade 1. Even grade 2 is not common.
So, in Dr. Hemant, in that patient where there was a urethrocuteus fistula repair, you approached from the perineum only?
Yes, sir. We have closed from the perineum only. Gosby. We actually, there was a fistula. We opened the wound again, and sir, in that we have not taken the sutures. Actually, I have inadvertently taken sutures from the transverse perineum muscle. That way, that is why now I take extra precaution. I see catheter and then I take sutures. I became a bit more confident and I just took the sutures from transverse perineum muscle. So we rectified that thing and then the patient was well. ठीक है ना? Go to
point.
I'll just put this thing and then they can close and we can have.
So this is suction drain you are putting?
Yes, sir. Suction drain, na? Yes, yes, sir. लो, काटो काटो इसे, काटो, काटो, कट करो यार जल्दी जल्दी यार, चलो, काटो, ये पकड़ो, यहाँ से भी कट करो. So we just want 3 or 4.
Yeah.
We can actually avoid this thing also, these drain, but normally we keep in all urethroplasties. चलो, मुझे तो सूचा दो. Any vehicle to. ड्रेन कर रहा है, कैथेटर खुला हुआ है ना, कैथेटर बंद तो नहीं है. फोर्सेप्स, I think sir this is a simple closure, nothing fancy in this. We'll just approximate with.
This patient is under epidural anesthesia or?
This was done under epidural, sir. But sir, this can be done under spinal anesthesia. I think 2 to 2.
That's fine.
Cut. उनको दे दे.
What is the anesthetist estimation of blood loss?
How much blood loss was there? Sir, 100 to 200 ml they are saying.
Okay.
So it will be around 200 to 300 ml because there are some mobs also.
But the fact is you don't need transfusions.
Sir, we don't need transfusion, sir. We don't need transfusion, and only thing is it's technically a bit difficult, sir, sometimes. Like in this case, most of the cases, sir, we wait for 6 weeks. Some of planes are better. Here we were stuck. We had some difficulty.
No, as long you remain oriented with the operation, then the difficulty can be easily overcome. Professor Venugopal, your comment, sir.
Sir, in fact, I must compliment you for the job that you have done. I think most important thing that I have noticed is know the anatomy well and you can get away with it. If you do not know the anatomy, the patient anatomy well, I think you are going to have a lot of difficulty. I think urologists today are not usually very much aware of the perineal anatomy as much as we used to do in the good old days. I think things have changed because mostly we have gone into endoscopic surgeries, and because of that, open surgeries have become a little taking a back seat. I think a job well done, and he showed some difficulties. And any operative procedure that does the workflow, I think usually you'll have some difficulty that you encounter as you go along. Thank you very much, Hemant, for a fantastic job done. Thank you.
Thanks a lot,
Very
sir.
good.
Thanks a lot.
Thank you, doctor.
Dr. Rajiv Sood is there. I think he can also give his comments if Dr. Rajiv Sood is there.
Yeah, I don't see him. Dr. Rajiv, please.
So it's coming on and off.
So simple. Now wound closure you can do, huh? So sir, they will do
So,
the wound closure. Now just in
Yeah.
2 layers they will close the wound, and this is the final.
Yeah,
we
very
don't
good.
apply.
Dr. Hemant, one question. So basically, you have gone behind the perineal body.
एक minute, just. Yes, sir. Sir. So what was the question?
Your approach has been behind the perineal body.
Yes, sir. The approach was behind the perineal body, sir. The lights super karna. Lights super. So sir, there was a question like if we have to do a stricture along with RP radical prostatectomy. So our approach was behind the perineal body. We were just anterior to this anal sphincter, and we went ahead. If we want to do a rectourethral fistula or we have to do a radical prostatectomy with a urethral stricture, what we will do is we will give a longitudinal incision simultaneously. First, we will give this incision. We'll separate prostate from rectum, and then we'll give a longitudinal incision. We'll do a second dissection in front of perineal body, like we do in urethral strictures. We will not disrupt the perineal body in that case. We'll do one dissection below the perineal body or radical prostatectomy or rectourethral fistula, and second dissection above the perineal body through a longitudinal incision. That will be for urethral stricture. So that is the way we do stricture along with radical prostatectomy or rectourethral fistula.
So the approach for radical prostatectomy, if you go in front of the perineal body, is it difficult?
If we go in front of perineal body. So sir, if we go in front of perineal body, we'll encounter the bulbar urethra. For prostatic urethra, we have to be behind the perineal body because the perineal body, there is a pelvic perineal diaphragm. So if we have to approach cranial to the perineal diaphragm. If for cranial to the perineal diaphragm, we have to be below perineal body. If we will go above perineal body, it will be distal to perineal diaphragm. Then we'll approach bulbar urethra.
The other day, I was doing a post-prostatectomy rectourethral fistula. We had gone in front of the perineal body, no doubt about it, and we could. It was done satisfactorily with the interposition of the gracilis muscle. So that's another difficult surgery. We don't see these cases very often. It was a open prostatectomy done somewhere up in the hills, and the patient had this fistula. He was diverted. And then he repaired it. Technically good operation. Let's see what the outcome is.
Yes. Sir, we have actually operated last week only one such case of post prostatectomy rectourethral fistula, and we did it in similar way. Actually, we deal here a lot of rectourethral fistula with PFUDD. They are more common actually. Post prostatectomy rectourethral fistula are less common. So we have operated last week. We have made a video also 7-8 minutes. So in that case, the approach was similar. Only thing in that we open rectum because we don't want to open the bladder part. Just we want to open sufficient enough so to close the bladder part. It is generally from the anastomotic side, but we generously open the rectum, so it can be easily repaired. The downward thing can be easily repaired. So in that case also we have opened the rectum. We identified the fistula from the perineum. We separated rectum from the bladder, and then we repaired bladder, then rectum. And we have not used gracialis in that case. Hopefully the patient is doing well. Next week the catheter will be out. We'll see the result.
Okay. So, Dr. Hemant, do you have a robot at your institute? No.
No, sir. No, sir. We are waiting. I think by the end of this year it will come.
For a radical prostatectomy, you have to approach either from perineum or from the open retropubic, or you can do laparoscopic. Do you do
Yes, sir.
laparoscopic?
Yes, sir. We do
Do you
laparoscopy
do?
both, sir, extraperitoneal and intraperitoneal. Both we do.
Okay, very good, very nice.
Actually, Dr. Umesh is doing intraperitoneal lap radical prostatectomy. I am doing extraperitoneal lap radical prostatectomy, and then open and perineal. Now, open retropubic is very uncommon. We are not doing. Perineal, we are doing.
Good, good operation, good demonstration. I must appreciate that.
Thank you, sir. So normally, sir, we'll remove the drain on the second post-op day, and third day patient will be discharged, and with normal diet, normal, and by 10th day we generally remove catheter. We advise Kegel exercise before pre-operatively only. We teach them Kegel exercise, and we expect grade 1 or grade 2 SUI at the time of catheter removal, which usually recovers by maximum by 1 month.
So of all the perineal prostatectomy, this is the talk these days about the preservation of the potency and erectile function. So here there is no conscious attempt to avoid damage to the nerves. You do an anatomical dissection and you hope that the nerves are preserved.
Yes, sir.
Okay, so of the 40 odd patients you have done, so did any patient came back saying that, well, I have lost my erectile function?
Sir, actually, the erectile function is lost in most of the patients. That is lost. I think in our radical prostatectomy, to preserve erectile continence is preserved, but erectile function, like it's not sufficient to have a sexual activity after radical prostatectomy in most of our patients. But there were few patients. I remember 2 patients who were fully like potent. They were the erectile function was normal and they were able to do sexual activity. But rest, I think around 80 to 90% patient, I counsel the patient, the erectile function will not be sufficient to have a sexual activity.
No, I must make it clear. We are removing the functions for organs for sexual functions. We are removing the whole of prostate. We are removing the seminal vesicle. We are ligating the vas deferens, obviously, and there is loss of bladder neck. So obviously, the patient will never have antegrade ejaculation. There is nothing to ejaculate.
Yes,
Only
sir.
thing, they will have a desire and they have an erection. If the erection is there, they would be happy for sufficient for penetration. That's my understanding. So
Yes, sir.
that is it.
Yes, sir. But sir, sexual, that we always counsel pre-op that sexual activity, the erectile function will be decreased or lost after surgery. Continence, we always explain, sir, the patient will be continent. It's very rare for a grade 3 SUI in any of that, and it's not acceptable after radical prostatectomy. So that we explain, it's very uncommon incontinence part after 1 month of surgery. But sexual activity is something we explain that it will be mostly lost. Like
Venugopal wants to give a comment. Yes, sir.
I think
Yes, sir.
this question of erectile dysfunction is much talked about in India and not that much importance as far as the erectile dysfunction is concerned. Most importantly, I think in my experience at least, a patient after 60, 70 rarely is much bothered about sexual life in this country like India. Maybe the advances that are occurring today with many people living to octogenarian age and nanogenarian age, maybe erectile dysfunction is coming to become a little more important. But still recently, I think most of my patients from whom I have done so many surgeries in the septuagenarian and octogenarian group, and even the 60s, they are not really bothered about sexual function as long as their urinary continence is maintained. The most important thing India wants is urinary continence and not erectile.
Very correct, sir. I'll ask one more question, Dr. Hemant. Of these 40 cases or so, whatever you have under your follow-up, did anybody come back with anastomotic stricture or urethral stricture or bladder neck contracture, anything?
Sir, there was one patient. I'll again, there was a different, that was not operated by me actually. That was operated in perineocon in a different institute. There was a rectal injury along with that. That patient had bulbar urethral stricture in follow-up. None of my patients I had any bladder neck stenosis or bulbar urethral stricture.
So they void satisfactorily. They are mostly continent, and their sexual function is as you explained.
Yes, sir. And sir, there is no stricture. There is no bladder neck stenosis. Bladder neck stenosis is 0. The urethral stricture is 0. Only thing, just when we introduce a lousely, we have to be very careful. That is why I always, and we have to do it before we fix the scrotum. After we fix the scrotum, it is very difficult to put any male dilate. So that we have to do initially, then we fix the scrotum. So I think these are some small steps we should take in any surgery. Take care in any surgery.
Okay. Okay. You obviously you select your cases for doing perineal prostatectomies.
Yes, sir.
What about the histology, margin positivity, and all those things?
Sir, now it has reduced. In initial, I think 10-20 cases, there were around 20% margin positivity, 10 to 20%. Now it is less than 10%, and the margins are generally positive at apex. But sir, the PSA is very well controlled. I just feel that we do a lot of manipulation at the level of prostatic apex, because we have put loosely, we are giving a lot of traction. Somehow that apex is a bit damaged. So I feel margin positivity is because of that. Otherwise, we have taken care of prostate under direct vision very nicely. It should not come positive. But most of the cases, they come positive at bladder apex, but they do well in post follow-up. Like hardly 3 or 4 patients we have offered radiotherapy. Otherwise, most are doing well oncologically.
Hemant, there is a
Fine.
question by Dr. Shekhar. He is asking whether laparoscopic pelvic lymph node dissection and you do posterior dissection laparoscopically and then do radical perineal prostatectomy. Will it be useful?
Sir, initial cases we have done, we were doing for high risk also. In that, we used to do a lap pelvic lymph node dissection, then followed by radical perineal prostatectomy. Actually, that was a bit difficult. It was not easy because the planes were already manipulated. So we somehow feel in this, sir, the posterior dissection was a bit difficult. Otherwise, it's the most easy part of the surgery. It's the most easy. The most difficult part is the initial part where we have to separate rectum, and second is when we're doing the bladder neck, separating the bladder neck from the urethra. So that's the most difficult. Otherwise, I don't think, sir, the application of robot will be helpful. Definitely, after we have divided the prostatic urethra at the level of prostatic apex. At that point, if we introduce robot, that will be very helpful. Before that, I don't think robot is also helpful because there is all blunt dissection. There is no natural planes which robot will create. So after division of the prostatic urethra at the level of prostatic apex, robot will be very, very helpful.
Yeah, there are a few centers are doing robot assisted perineal prostatectomies.
Yes, sir. So I think the initial half is done open, and then they dock a robot and they do the procedure, and it will be very helpful for doing a perineal lymphdectomy also. Today, because the procedure was a bit difficult, so I have not shown perineal lymphdectomy. Maybe some other time. Otherwise, we can just create perivesical space. We can put silk port and we can show that anatomy. But doing laparoscopically is a challenge to do a lymph node perineally.
Okay, I must thank you.
Thank you, Hemant, for a wonderful
Good job done.
demonstration. There was a lot of comments in the chat box congratulating you for a wonderful demonstration, although it was a difficult case. And let me thank on behalf of the USI for your effort to do this webcast and all your team, the team of the associates, the residents, the nurses, OT staff, anesthetist, all of them who have worked on a Sunday morning to get this live transmission. On behalf of the USI, I thank all of them. And I also thank the sponsor Sun Pharma for giving us a grant for doing this webcast. And over to you to give your valedictory address.
Thank you, sir. I really thank Urological Society of India, the president, the secretary, sir, the entire council, Dr. Arum Mandal, to supervise this session. And they have given. We were looking forward for this opportunity to demonstrate radical perineal prostatectomy. Thanks a lot. Also, at this outset, I would like to thank our ex-department of head, Dr. Rajiv Sood, sir. Actually, he started the procedure. He procured the Lausler tractor. Somehow we have taken over that legacy. We are trying to improve the procedure. The entire department, Dr. Umesh is there. My entire department, residents, they all are very helpful. And the plus point of RML is the teamwork, sir. The entire department is always together. The residents are always together. We are well supported by our OT staff, anesthesia department, they are working on Sunday, which is very rare in a government institute. And they were here at 8:30. The patient, the induction was difficult. That is why we started a half an hour late. And I think the plus point of RML is the teamwork. I'm blessed to have such a department, such OT staff, anesthesia department, our administration. They are all very helpful. They promote us to do good urology work. Thanks a lot.
Thank you.
Thank you, Hemant. Wonderful demonstration.
Thank you, sir. Thank you. हो गया मुश्किल हो गया था